minutes before we get going. So drop your name and where you're participating from today. Welcome, welcome, welcome. We have about 80 people right now on the chat. That's really, really good. So please keep writing down your name and where you're participating from today. I can see people from Cameroon. I can see people from Etiosa East here in Lagos, from Ghana, from Abuja. Welcome. From Lagos, Nigeria. From Kanu. From Niger State.
Hello.
Can everyone hear me? There's someone on the chat who says they can't hear. Can you hear me okay?
We can hear you, Pamela.
Yes, we can hear you.
Oh, fantastic.
Can I just give you an information?
Yes, please go ahead.
Yeah. Professor Oloko just called me that it's raining heavily where he is. He's trying to join without luck, but he has sent a pre-recorded presentation. In case we have problems getting him started, can we get his recorded presentation ready? Thank you.
Yes. Yes. Thank you very much.
Thank you.
Welcome, everyone. For those who have just joined, my name is Pamela. I'm head of MQN here at mDoc, and our webinar series for today is in partnership with the Nigerian Hypertension Society. And the theme is Deadly Twin of Hypertension and Diabetes, Storm of Pressure and Sugar in One Cup. That sounds very interesting, and I'm looking forward to learning and gaining knowledge like I'm sure most of us are. So if you're just joining us, please write your name in the chat and tell us where you're joining us from today. You see people joining from Sokoto, from Ikeja in Lagos, Lasuth in Ikeja. Some more Abuja people, welcome. From Port Harcourt, welcome. From Jos, welcome. From Jigawa State, welcome. Just 3 more minutes and then we'll start. Wow, we have someone who's just joined us from Milton Keynes in the UK. Welcome. We have someone joining us from Bloemfontein in South Africa. Welcome. Okay, we're going to start now. Good afternoon, everyone. Once again, welcome to this webinar series in partnership with the Nigerian Hypertension Society. My name is Pamela Igbo. I'm the head of MQN here at mDoc. And today's theme is Deadly Twin of Hypertension and Diabetes in Nigeria, Storm of Pressure and Sugar in a Cup. So just to move forward, we're just going to have some housekeeping things before we start in earnest. So just some key tips to follow. Please have your camera on. It just makes for greater engagement and it makes it more lively. The session is recorded. And so please raise your hand if you want to ask a question and one of our co-hosts will let you speak. Write any questions you have in the chat and please keep your opinions very, very respectful. Thank you very much. So just take note that this session is recorded for data protection purposes. The data is used for reports, maps, communication surveys, quality assurance, evaluation research to inform our new initiatives. So as you can see here, we have a packed agenda for today. We have 7 professors here on this call, and they will be introduced very shortly, but it is a packed schedule for today. So please try to pay attention, enjoy it. If you have any questions, please put them down on the chat, and we will have a section where we're asking questions and those questions will get answered as much as we can. So thank you very much. So as reiterated earlier, our partners today for this webinar is the Nigerian Hypertension Society in collaboration with mDoc Healthcare. I'd like for us to give them a thumbs up and welcome them warmly. Welcome, welcome to all our participants from the Nigerian Hypertension Society. Welcome. Thank you very much for joining us. We're so excited today. So for those of you who might not have heard of mDoc, those of you who might be joining us for the first time, so I'll just introduce what we do to you. mDoc Healthcare is a digital healthcare social enterprise. We're focused on optimizing end-to-end self-care experience for people with regular and chronic health needs. We harness quality improvement methodologies, data, behavioral science, and technology. And our goal is to ensure that people live healthier lives and more productive lives, not just in Nigeria, but in Africa as a whole. And this support that we give is provided by our 4 pillars. We have 4 pillars that we focus on to deliver our self-care agenda. And that is, number 1, a complete health platform. It's a digital healthcare platform that enables self-care. We give virtual self-care for people who need that support. Our second pillar is NaviHealth AI. It's our digital navigation system where patients can find facilities close to them and also leave reviews for better quality improvement in those facilities. We also have our Nudge Hubs. This is our tech-enabled community-based hubs where people can walk in and get the support that they need and also get health education. So finally, our final pillar is our mDoc Quality Network, and that's why we're here today. We do capacity building for healthcare workers, policymakers, and for individuals who want to learn more about self-efficacy and how they can better their health. So just for the doctors in the house, I'd like to say that mDoc has partnered with Sub-Saharan Healthcare Solutions to provide CPD certification for doctors. So if you're interested, please send an email to us at mqn@mymdoc.com, and we'll be able to facilitate that certification for you. So right now we want to do a pre-quiz and I'd love for everyone to participate in it. The reason for the pre-quiz is just to gauge the level of knowledge before the talks. And then we will have this same post-quiz at the end just to see how much we've gained from it. So I'd like for everybody to participate. You should see on your screen right now a pop-up with the questions rather. Please let's participate for the next 5 minutes. They're just 5 questions, so it shouldn't take you too much time. If you have problems seeing the quiz, please let us know in the chat. I hope everyone's taken the quiz. It's just 5 questions. Shouldn't take you time at all. 2 more minutes. For those of you who can't access the quiz, there on your screen, you should see 3 dots where it says more. If you click on it, you will see polls and quizzes, and it should come up. Please, let's all try and take the quiz. As many of you that can take the quiz, that would be great. So if you can't see it, just click on those 3 dots and you should see polls and quizzes and it will pop up. And you just click on polls and quizzes. So I'll just give everyone else 1 more minute and then we're done. Give me a thumbs up if you've actually done the quiz and you've finished. Great. Okay, so we're going to move on now to the rest of the program. Thank you for all those who have taken the quiz. So right now, I would like to introduce my co-facilitator. He is the current Nigerian Hypertension Society Secretary, Dr. Oladipupo Fasan. He's going to be co-facilitating with me today. I'd like for us to give him a thumbs up, an emoji, welcome him, and he's going to lead the session, some of the session from here on out. Welcome, Dr. Oladipupo. You have the floor.
Thank you, Pamela. Thank you. Welcome, everybody. Thank you, and we appreciate your attendance at this meeting. As usual, this is one of the programs that the Nigerian Hypertension Society runs every year, and we've been doing this in conjunction with mDoc. So thank you, mDoc, for being our partners. As we said, today's webinar is titled The Deadly Twin of Hypertension and Diabetes in Nigeria, Storm of Pressure and Sugar in One Cup. I'm glad to introduce the chairman of today, Professor Obasonha, and as well as the president, our able president, the president of Nigerian Hypertension Society, Professor Isezu. They will be giving us their welcome address and goodwill message. So Professor Isezu, please have the floor.
Thank you, First Secretary, for the introduction. I want to, on behalf of the Nigerian Hypertension Society and mDoc 2, to welcome all of you to this national webinar marking the World Hypertension Day. This is the third in the series in the last 3 years since we took over the leadership of the society, and we've been doing this for the past 3 years with mDoc. This year's World Hypertension Day theme is controlling hypertension together. It is in this spirit that we think that this year we should gather experts from different fields, cardiologists, endocrinologists, diabetologists, nephrologists, family physicians, and in fact, all of us, to look at a problem that also occur together most of the time, hypertension and diabetes. It is our hope that at the end of this program, we will all know what is the burden of this hypertension and diabetes combining together in the Nigerian population. We should also be able to have information and knowledge about why the combination of the two leads to almost additive or putative morbidity or mortality or disability and death. And perhaps more importantly and more interestingly is for us to start thinking of integrated care of this condition that occur together, particularly or at least among patients with both conditions that are stable. Patients who currently, going by the current practice, will probably on a day of the week attend hypertension clinic, and another day of the week come for diabetic clinic, with all the implications for time and money or finance. I'm sure we are still going to express our appreciation, but I will not complete this opening remark or welcome address rather without thanking mDoc for being a valuable partnership, thanking our eminent resource persons who, despite their very, very tight busy schedule, they still find time to honor our invitation. And of course, to thank our very, very senior colleagues who has agreed to chair this occasion, one of the prominent cardiologists in the country today, Professor Basahab. Thank you, sir. Thank you very much. Over. First.
Thank you, sir, Professor Isezu, for that brief welcome address. Professor Austin Obasanwa is an emeritus professor at the prestigious UBTH, University of Benin Teaching Hospital, University of Benin. He is the chairman of today's program, and I welcome him to make a quick comment. Professor Obasanwa, sir.
Thank you very much, Secretary of the Nigerian Hypertension Society. Let me join the chairman to welcome everybody to this year's webinar and to also join him to thank our partners over the years, mDoc. Today's webinar is an interesting one, and it focuses on the twin disease of hypertension and diabetes that occur quite often concomitantly and having interdependence or interrelationship in many ways. We welcome the various experts who will dilate up and address the issues of this twin disease as it relates to their specialties and to their areas of practice. It is an opportunity to enhance our knowledge, not only in the presentation, but in the management of these conditions, both individually and jointly. The quiz that has been taken assesses the basic knowledge, and we hope that at the end of the day, there probably will be a post-quiz which will show improved knowledge from participating in this conference. So I join the executive to welcome everybody and to eagerly await the knowledge to be shared by various experts. Thank you very much, Mr. Moderator.
Thank you, sir. Thank you for the goodwill message, and we really appreciate you. You are one of our mentors, fathers in the profession, and we are glad you could make this meeting. Thank you so much. I will move on now to introduce our key speakers. The first speaker is Professor Uloko. Professor Andrew Uloko is a professor of medicine and an endocrinologist at the Bayero University, Kano. He's a consultant endocrinologist at the Aminu Kano Teaching Hospital, Nigeria. He is the president of the Endocrine and Metabolism Society of Nigeria, EMSON, and a leading expert in diabetes care, endocrinology, and metabolic diseases. An accomplished researcher and educator, he has over 95 peer-reviewed publications and is actively involved in national and international diabetes research, guideline development, and medical education initiatives. Please welcome Professor Uloko. We move to the next speaker. The next speaker is Professor Helen Mammak-Mamven. She's a consultant physician and nephrologist at University of Abuja Teaching Hospital, as well as being a senior lecturer at the University of Abuja, Nigeria. She's a clinical translational scientist with research interest in non-communicable diseases, chronic kidney disease, hypertension, data science, and artificial intelligence. She serves as principal investigator for the H3 Africa Kidney Disease Research Network Abuja site, and currently she serves as our able vice president. She is the able vice president of the Nigerian Hypertension Society. Please welcome Professor Mammak-Mamven. I move on to the next speaker. The next speaker is Professor Sani Atta Abubakar, a professor of medicine and a neurologist at the Ahmadu Bello University, Zaria. He is also the head of the neurology unit at the ABU Teaching Hospital in Zaria. He is a leading researcher in stroke, neurodegenerative diseases, and neurological genetics in Nigeria. He serves as principal investigator and collaborator on several major national and international neurological research projects with extensive experience in stroke genomics, neurobiobanking, and preventive health research. Ladies and gentlemen, kindly help me in welcoming Professor Sani Abubakar. For now, in the first stanza, I will go ahead to introduce Professor Okechukwu Samuel Oga. Professor Okechukwu Samuel Oga is a professor of medicine at the University of Ibadan, an honorary consultant cardiologist at University College Hospital, UCH Ibadan. He is the immediate past president of the Nigerian Cardiac Society and currently chairs the society's scientific committee. He's an accomplished cardiovascular researcher and clinician. He has over 230 peer-reviewed publications with research interests spanning hypertension, heart failure, hypertensive heart disease, and atrial fibrillation. Please join me in welcoming Professor Okechukwu Samuel Oga. At this point, I will briefly want to talk about the Nigerian Hypertension Society. The Nigerian Hypertension Society has been around since 1993, and we currently run our thank you. We currently have our website, which is tnhs.org.ng. We invite everyone who is involved in the story of hypertension to please come and join us. We are a group of researchers, doctors, nurses, pharmacists, public health physicians, individuals who are interested in hypertension, community health workers, non-governmental organizations, we are all part of the Nigerian Hypertension Society. Our website is tnhs.org.ng, and we have a Twitter handle, which is at TNHS1993. Well, Twitter is an old name, so we call it X handle. X handle. So X or Twitter handle at TNHS1993. We welcome everybody. The Nigerian Hypertension Society is a vibrant society, and we are here to help in the prevention, detection, treatment, awareness campaign, and advocacy for hypertension in Nigeria. So, that said, so that I don't waste too much time, we will be inviting Professor Uloko, who will be the first speaker. He will be talking about prevalence and determinant of high blood pressure, diabetes, and high blood pressure diabetes together, looking at the urban versus rural and age group differences. Thank you. Professor Uloko, please, you have the floor.
So Professor Luko is having some problems with his network. So this is going to be a pre-recording that he sent to us.
Can we work on the volume, please?
Sorry, good afternoon, distinguished ladies and gentlemen. I've been having some challenge with my network, but I think I can try to share my slides now, since this pre-recording is not having an audio. Pamela, sorry, I don't know if I can try it from my end.
Yes, you can. Roderick, he wants to share his slides.
Let me see. I'm trying to share my slides. Sorry, is my slide visible to everybody now?
No.
Not yet. Oh, yes, yes, it is now.
Okay. So, good afternoon, distinguished senior colleagues. It's my pleasure to be here this afternoon to participate in this very important webinar, the World Hypertension Day 2026. In the course of my discussion, I will be looking at the epidemiology of hypertension and diabetes mellitus in Nigeria. We know that the prevalence of diabetes in the world is about 589 million people currently affected. And in Africa, 25 million people are currently affected as an estimate. And these figures are expected to double in the coming 10 to 15 years.
Professor Oloko, you are sharing the wrong screen, sir.
I'm sharing the wrong screen?
Yes.
Yeah.
Yeah, but what is on my screen here is prevalence and risk factors for diabetes mellitus in Nigeria. Can you see this?
No.
No.
Okay.
Now we
We are
can.
seeing it now.
Yeah.
Okay. So the current prevalence of diabetes in Nigeria is estimated to be 5.77% in a meta-analysis we conducted in 2018. Before now, the prevalence was 2.2%, as published in the 1997 Non-Communicable Diseases Survey. And there has not been any other population-based study until this meta-analysis, and that was part of the motivation. The risk factors for diabetes in our assessment were unhealthy diet, physical inactivity, advancing age, obesity, family history, urban dwelling. When we looked at the 6 geopolitical zones across Nigeria, the South-South zone predominated, followed by the Northeast and the Southwest. Barely 6 years later, there was another systematic review and meta-analysis by Olamayogun et al., in which he found the pool prevalence of diabetes to be 7%, a slight increase over what we got earlier on. And the South-South zone still predominated by about 11%, and the risk factors were quite similar to what we found in 2018: family history, socioeconomic status, physical inactivity, urbanization, and abdominal obesity. Let's look at hypertension in Nigeria. To do this, I tried to look backwards so I could follow some trajectory. Way back in 2015, in this study published by Akinlua, a systematic review that looked at the current prevalence pattern of hypertension in Nigeria, they found that in children, there were 0.1 to 17% prevalence of hypertension in children, and then the range was 2.1 to 47% in adults. In most studies that they reviewed in that systematic review, the prevalence of hypertension was higher in men than in women, and the prevalence across urban to rural ranged from 9.5 to 51% and 4.8 to 44% respectively. So Akinlua and colleagues concluded that the prevalence of hypertension is high among Nigerian populations, and appropriate interventions was needed to develop and implement to reduce the burden of hypertension, especially at the primary healthcare level. In another study, this one was a nationwide study conducted by Odili et al. In this landmark study that looked at the prevalence, awareness, treatment, and control of hypertension in Nigeria, they found that the prevalence of hypertension in Nigeria currently stood at about 38.1%. And the prevalence of hypertension increased from 6.8% among subjects that were aged less than 30 to 63% amongst those that were aged 70 and above. The prevalence did not differ significantly from urban to rural, 39% versus 37%. And the prevalence across geopolitical zones recorded highest prevalence in the Southeast with 52%, South-South 44%, Southwest 42%. Odili et al. Concluded that large burden of hypertension is prevalent in Nigeria, and closing up of the urban-rural gap previously described was quite prominently observed. Quite recently, just barely a month ago, there was this very interesting systematic review and meta-analysis published in BMC Cardiovascular Disorders by Nwankwo et al. They looked at the prevalence of hypertension among adults in Nigeria, and they found some 34% of Nigerians are currently living with diabetes, a figure that was quite similar to what Odili found in 2017. And males were more affected than females, 41 versus 32%. And the prevalence across zones showed this time around that the Southwest predominated with 41%, the South, North Central 38%, and the South-South 32%. Approximately 1 in 3 Nigerians now live with hypertension. And the urban-rural prevalence that was previously known many years ago has now equalized. The sex differences was not significant, and the need for continuous surveillance and intervention was recommended. Let's look at hypertension in people living with diabetes mellitus. To do this, in the landmark study of Diabcare Nigeria conducted in 2008 across 6 geopolitical zones involving 7 tertiary health centers, we evaluated 531 Nigerians living with diabetes mellitus. And we found in that study that over 60% of Nigerians with diabetes had hypertension, with a mean systolic blood pressure of 142 and diastolic blood pressure of 80 millimeters of mercury. We also found out that less than 1 in 5 patients with diabetes that have hypertension had good blood pressure control if you use the ADA recommendation of BP of less than 130/80. And most of these our patients were not optimally controlled in terms of glycemic control, with just 1 in 3 of our patients achieving treatment target. Brazil in 2025, just last year, looked at hypertension in type 2 diabetes mellitus, prevalence patterns, determinants, and implications for cardiovascular risk prediction in a population of Nigerian patients. This study was carried out in north-central Nigeria and looked at a large population of persons with diabetes. In their cohort, they found hypertension to be prevalent in about 65% of these patients with type 2 diabetes. And the independent predictors they identified were long duration of diabetes, high sensitive C-reactive protein. The conclusion they drew was that hypertension is highly prevalent among type 2 diabetes patients in Nigeria, and systemic inflammation, long duration of diabetes, high cardiovascular risk were associated with hypertension in people with diabetes. They recommended adequate and prompt blood pressure control, monitoring of inflammatory markers, and control of cardiovascular risk factors. How about rural-urban comparison of both hypertension and diabetes? It's clear from the available evidence that currently, if you take hypertension, some 20 to 35% of rural populations are affected, as compared to 30 to 45% of patients in the urban setting. And the drivers for the high prevalence in the urban population revolve around sedentary living, unhealthy lifestyle, the raging epidemic of obesity, additional stress, and dietary changes. Rural populations, as we have seen in the previous research that I showed, have now equalized. It was previously thought that it was lower in the rural population, but it's now equalized with urban populations. For diabetes, 2 to 5% of rural populations now have diabetes mellitus type 2, and it's in the urban setting, it's about 6 to 12%. And it remains more common in the urban setting for quite similar reasons as for those of hypertension: westernization, sedentary living, unhealthy lifestyle, and metabolic risk factors. Undiagnosed hypertension remains high in rural communities and is quite moderate to high even in the urban settings. The observation is that there is limited screening and healthcare access, contributing to underdiagnosis, especially in the rural areas. And for diabetes undiagnosed, it's quite common both ways. We know that many Nigerians with diabetes remain undiagnosed until complications develop. Our experience is that at the time of presentation, they have developed one or two chronic complications and sometimes even acute complications. How about the prevalence of hypertension and diabetes in Nigeria in terms of age group? We have seen that as age increases for both hypertension and diabetes, the prevalence figure increase. So if you follow this table down the line from childhood through adolescent, young adults to older adults, the prevalence is on the increase. And the major determinants include, for the younger age group, mainly lifestyle issues, unhealthy diet, some bit of family history, and sedentary living. For those that are in the active young age, 20 to 39, stress, alcohol use, I bet to add substance abuse, cigarette smoking, and obesity are known drivers. Yeah. And as age increases, we see the role of insulin resistance, the role of aging, and then chronic obesity with reduced physical activity contributing as main determinants of hypertension and diabetes in these populations. I close and I thank you. I hope to take your questions. Thank you very much. Hello, I don't know if I'm audible.
You are, thank you.
Okay, thank you.
Dr. Faso. Dr. Faso.
Hello, Dr. Fasson. Can you hear us?
Okay, I think we
Okay.
are having problems.
Problems. Okay, so I'll just take over.
Yes, please.
Thank you very much, Professor Oluko. That was very, very insightful. We'll have an opportunity to take questions at the end. So we're just going to move on to our next speaker, who I believe is Professor Manmak Mamven, and she will share her slides with us. Over to you, Professor Mamven.
So good afternoon, everybody. Am I audible? So I am happy to present this topic on the twin engines of renal decline, how hypertension and diabetes will drive chronic kidney disease. So over the next 10 minutes, we're going to look at an overview of the kidney and see how high blood pressure and hyperglycemia act as a devastating duo. So while hypertension is a hemodynamic insult, diabetes is a metabolic insult, and both lead to the final common pathway, that's intraglomerular hypertension and fibrosis. So the previous speaker has spoken a lot about the burden, the epidemiology of hypertension in Nigeria, the epidemiology of diabetes mellitus in Nigeria, and then the comorbid state of hypertension and diabetes. So he has given us, some up-to-date figures about it. So I'll hammer on the triple threat. Now that's hypertension plus diabetes and CKD. So we can see that it is a big burden to these three comorbidities, and the eventual clinical consequence is end-stage renal disease and increased mortality. So back to the triple threat again, triple threat of hypertension, diabetes, and CKD. So it's a massive hidden global health burden and one of the largest chronic kidney disease cohorts where diabetes and hypertension drive over 80% of the global end-stage renal disease cases, and hypertension is nearly universal, that 85 to 90% of patients with both diabetes and have advanced chronic kidney disease. And then to make matters worse, 90% of the individuals in the early stages of all these conditions are completely unaware of their kidney failure. So, and then looking at the risk profile, we know that primarily hypertension and diabetes, cardiovascular disease is the #1 killer amongst these two and the three, sorry, among the triple threats. I don't know if because it's raining heavily here. So we can see that as the combinations increases, we see that hypertension and diabetes has a 4 times risk of causing cardiovascular death, while the triple threats increases to about 6 to 8 times. So we can see how it increases with additional comorbidity. So what is the mechanism of this injury? Call it the double hit. While we have the metabolic engine on one end due to chronic hyperglycemia, we have the hemodynamic engine on the other end, which is caused by the systemic arterial hypertension. So we look at it one by one. What's the metabolic cascade of diabetic injury? We remember this landmark paper by Brownlee, who elucidated how chronic hyperglycemia induces kidney damage. He looked at the age, that's the advanced glycation end products formation, where there's irreversible glycation of protein, polyol pathway leading to oxidative stress, the protein kinase C activation, which leads to inflammation and vascular impairment, and then the hexosamine pathway, which increases the gene expression and upregulates transforming growth factor beta. Then this tubular interstitium is not spared in diabetic kidney disease too. Another landmark paper by Gilbert and Cooper also described how this transforming growth factor B activation is a central driver and buildup of a driver of extracellular matrix buildup and tissue fibrosis. Then hyperglycemia, oxidative stress causes protein leakage, and then interstitial fibroblast proliferation, and convert into myofibroblasts, and then the proteinuria, which is not just a massive marker, but it's also toxic and a direct promoter of tubulointerstitial inflammation. So the newer newer researches have shown the evolving pathophysiology of diabetic kidney disease, which is a complex interplay of this cellular specificity. You know, in the cellular specificity, we've talked about the hyperglycemia, which activates the protein kinase C, and then it triggers podocyte apoptosis and localized microvascular stress. Then the inflammatory axis, which is driven by macrophages and the neutrophil extracellular traps, which activates the myelocytes. And then we have the tubular network. Of course, recently we've heard about the SGLT2, which mediates hyperreabsorption in the proximal tubule and causes hypoxia. This deactivates the tubuloglomerular feedback mechanisms and triggers vasodilation and severe hyperfiltration stress. And then the metabolic memory, where epigenetic signatures keep the fibrotic genes active so that even after achieving subsequent strict control, this renal failure is still precipitated. So let's look at hypertension. How does hypertension cause this? So how hypertension and podocyte injury drive glomerulosclerosis? We all know that high blood pressure causes impaired autoregulation in the glomerulus because of the myogenic tone is reduced. So when this systemic blood pressure is high, it is transmitted directly into the glomerular capillaries. So this causes barotrauma and accelerates the glomerulosclerosis, then affecting the podocytes. This high blood pressure affects the podocytes with strain. So the podocytes, which normally do not proliferate, have this mechanical problem with stretching. So it causes the they become injured. The food processes become injured, and there's podocyte detachment, which is otherwise called podocyte fallout. And then there's denuded glomerular basement membrane, and then adhesion to the Bowman's capsule. So these two converge to double the consequences and the injury that happens. So let's look at the mechanism again. So for the oxidative stress, in the diabetic action, there's reactive oxygen species from glucose metabolism, while hypertension, mechanical shear, causes stress on the endothelium. So what's the common outcome? There's endothelial dysfunction. So in the RAS activation, there's intracellular RAS is triggered by glucose. And then the systemic RAS in hypertension is triggered by the low perfusion. So what happens? Common outcome is the podocyte injury. And then we look at the inflammation end. There's cytokine release. The transforming growth factor beta is also, the gene expression is also activated. And then in the diabetic action, there's pressure-induced inflammatory markers. Cytokines are also released. So what happens? There's tubulointerstitial fibrosis. And then messenger expansion occurs in both of these conditions. So which is compounded by triggering the messenger cells to excessively lay down collagen matrix. This progresses to nodular sclerosis. So this is the diagram I put up to show us the integrated mechanistic flow from hyperglycemia plus hypertension, leading to podocyte loss and glomerulosclerosis. So we can look at them and follow them up and see just what I've explained earlier on. So with this injury happening in the glomerulus and the tubules, there's a continuum of the progression of the sclerosis. So what happens? There's hyperfiltration in the nephrons. The EGFR becomes very markedly elevated, greater than 120. Then there's albuminuria, glomerular basement membrane filters start displaying the structural leakiness, then fibrogenesis, and then nephron fallout. And this continues in a vicious cycle, glomerulosclerosis, till eventually it culminates into severe decline in the GFR and end-stage renal disease. So now with all these things that I've explained, what are the therapeutic targets along this pathway? So let's look at the disease process now. The metabolic overload, that's on the hyperglycemia. What's the therapeutic intervention? The SGLT2 inhibitors and the glycemic regulation index. I've mentioned the SGLT2 causing increasing absorption of glucose in the tubules. So what's the mechanism? It restores the tubuloglomerular feedback to constrict the afferent vessels and improves glycemic load. And then in the hemodynamic stress, the afferent vasodilation and the high intraglomerular pressure that occurs, therapeutic intervention is ACE inhibitors or ARBs, and these dilate the efferent arterioles to reduce intraglomerular pressure, and they limit fibrosis and reduces protein leakage. And then the non-steroidal MRAs, as finerenone, they also reduce the microvascular inflammation and tissue remodeling. So they inhibit collagen deposition and tissue scarring. Then overall in the structural damage, that's the podocyte detachment and the denuded GBM, a lot of work has been going on the therapeutic intervention. So it's the anti-TGF beta therapies, which affect the podocyte cytoskeleton. So I've just put up a reference to show the landmark clinical trials that we all know about, from the renin-angiotensin system blockade to the SGLT2 to the non-steroidal MRAs, and then to the blood pressure control. So in conclusion, I know this is a very short presentation. Try to compress everything into 10 minutes or 8 minutes. So in conclusion, to save the kidney, we must treat both the pressure using ACE or ARBs to dilate the efferent arteriole and the metabolic flow using SGLT2 inhibitors to constrict the afferent arterioles. So the treatment of chronic kidney disease is no longer just about lowering blood pressure or lowering blood sugar. It is about protecting the microarchitecture of the nephron from the synergistic barotrauma and the metabolic toxicities of these two giants. So I want to end my presentation here, and I hope I have refreshed your minds and your memories about this pathophysiology of these two devastating conditions. Thank you.
Thank you. Thank you so much, Professor Manven, for your elucidating and fantastic presentation. We would like to move on to our next presenter, who is still talking about pathophysiology. However, he'll be looking at it from the aspect of stroke. He's a neurologist. So we're talking about how hypertension and diabetes drive stroke. I'm introducing again Professor Sani Abubakar. He'll be sharing his slides. Please keep your questions coming. Just put them on the chat. When we are done, we will go through them. I want to recognize a few people I can see that has joined us since we started. I can see Professor Ogunkule, Dr. Osiobu. I can see one of my most.
Have you seen my slide?
Yes, we can. Dr. Bulu
Put it
Juroye.
on slideshow.
Please put it on slideshow. So you can go ahead, please.
Good afternoon, my distinguished senior colleagues. I want to thank mDoc and the leadership of the Nigerian Hypertension Society for this opportunity. I'll be talking about pathophysiology of stroke in relation to hypertension and diabetes mellitus. Stroke is a major cause of long-term disability and death, and it's a disease of public health importance. Therefore, focusing on prevention is quite crucial. The most prominent target of this prevention is to treat the modifiable risk factors. And what are they? Systemic hypertension and diabetes mellitus in one series. Those efforts must be made to control the blood pressure and to optimize glycemic control. Stroke traditionally is divided into ischemic stroke and hemorrhagic stroke. And we're going to approach this pathophysiology in this direction. Let's start with ischemic stroke. Long-standing uncontrolled arterial hypertension and diabetes mellitus cause structural and functional changes in cerebral vessels, making them prone to occlusion. High pressures in those vessels causes damage in the small penetrating arteries, and these are the lenticulated tight arteries that deeply penetrate into the brain tissue. This results in the thickening of the vessel wall with the deposition of lipid-filled hyaline materials and narrowing of the lumen. This is what is called lipohyalinosis. The resultant effect is that the vessel progressively gets narrower, and over time, there's occlusion. And when there's occlusion, there's a distal infarction. And that's what results in the lacunar infarction that we know. And usually take place in deep areas in the basal ganglia, thalamus, pons, and the internal capsule. Diabetics with poor glycemic control, in addition, could lead to micro and macroangiopathy in the large and small penetration arteries. This also cumulatively could result in lacunar infarction. The other mechanism that is quite clear is the formation of microarthrioma. We do know that hypertension and diabetes mellitus combined accelerate atherosclerosis in the intracranial arteries, notably the middle cerebral artery. And it also causes microangiopathy in the small penetrating arteries. This may lead to formation of plaques within the lumen and promote thrombosis. In the end, that could result in occlusion or arterial embolism, and the distal infarction could result in lacuna. There is this phenomenon of cerebral autoregulation. The brain is tightly controlled by autoregulation, so that when the blood pressures are increased, there's cerebral vasoconstriction, so that it will limit the supply to the brain. And when there's a reduction in blood pressure, there's cerebral vasodilation, so that the supply will be optimized. But this is tenable when the blood pressure is, when the mean arterial pressure rather, is between 60 to 150 millimeters of mercury. In chronic hypertension, there's a shift of this autoregulation to the right, meaning that high pressures now are set for this auto supply, so that when the blood pressures are aggressively lowered, which is what we see in some clinical practice, they even to normal level, the blood supply to the brain become compromised, and we have what we call watershed infarction or thrombotic infarction. The pathophysiology for hemorrhagic stroke is quite different from that of ischemic stroke, and it's called hypertensive intracerebral hemorrhage, which notably take place in the basal ganglia, the pons, the cerebellum, and the thalamus. Chronic hypertension leads to generation of the smooth muscle walls of the penetrating arteries. This results in the formation of tiny circular microaneurysm, and they are called Charcot-Bouchard aneurysm. This aneurysm takes place at branch points in the arteries. The wall of these aneurysms are quite weak, and when there's a sudden rise in blood pressure, they could also rupture. The other mechanism is fibrin node necrosis, where severe or accelerated hypertension causes necrosis in the vessel wall. With the deposition of fibrin node materials, all this result in the weakening of the arterial wall, which ultimately are prone to rupture. How does the rupture take place? Usually when there's a sudden rise in blood pressure, either from stress or exertion, or suddenly somebody who's on antihypertensive and maybe withdraws the drug, the weakened vessels now cannot withstand the pressure, and it exceeds its tensile strength, and you have a rupture of the blood vessels, and they'll be bleeding directly into the brain tissue. The blood extravasate into the brain parenchyma, causing mechanical destruction, mass effect, and secondary injury from blood product. Usually ammonia can be reduced, it can be released, resulting in inflammation, excitotoxicity, and all this will result in worsening of injury, in addition to raised intracranial pressure from vasogenic edema. Then I'll talk about the role of autoregulation, impaired cerebral autoregulation in both ischemic and hemorrhagic stroke. The normal autoregulation, which I previously explained, entails that the blood pressure, the blood supply to the brain is tightly controlled by phenomena of cerebral autoregulation. High blood pressure disorganizes this arrangement and shifts the autoregulatory curve to the right. And over time, with increase in blood pressure, there's a breakthrough of this autoregulation, causing forced vasodilatation, endothelial damage, hyperperfusion, and vasogenic edema. All this can result in what we refer to as obstructive encephalopathy, and in some instances could result in direct bleed into the brain. So you have failure of the autoregulation, passive vasodilatation, increased allostatic pressure, leakage or rupture of the vessels, resulting in vasogenic edema. Then understanding the all concepts that I've been discussing, I choose to present this slide in, so I call it understanding the pathophysiology. In ischemic stroke, the lesion is lipohyalinosis and microatheroma. In hemorrhagic stroke, we have Charcot-Bouchard aneurysm and fibroid necrosis. The vessels involved are usually small penetrating arteries, in both cases, both hemorrhagic and ischemic stroke. In ischemic stroke, there's occlusion resulting in an infarction. In hemorrhagic stroke, there's a bleed, a direct bleed, resulting in release of blood into the brain tissue, which could also track into the ventricular system, which traditionally they call primary intracerebral hemorrhage with extension into the ventricular area. The common site involved is the putamen, the thalamus, the pons, and the internal capsule. The basal ganglia are also involved, also in hemorrhagic stroke. What is the clinical correlation of this? Hypertension is the single most important risk factor for both lacunar stroke and intracerebral hemorrhage. Tight blood pressure control prevents development of lipohyalinosis, microaneurysm, and thereby reducing both types of stroke. In acute ischemic stroke, guidelines permit higher blood pressure to maintain coronary circulation. This is what is called permissive hypertension. But in hemorrhagic stroke, blood pressure reduction is critical in order to prevent a rebleed. So with this, I believe I've refreshed your mind on the pathophysiology of both ischemic and hemorrhagic stroke in relation to hypertension and diabetes mellitus. Thank you very much. Over.
Thank you, Professor Sonny. That's a very enlightening presentation. We'll be going to the next speaker. The next speaker will be talking about, still on pathophysiology, we'll be talking about how hypertension and diabetes drive heart failure. Please permit me to introduce again Professor Okechukwu Samuel Oga. Professor Oga, please take the floor. We can't hear you yet, sir.
Can you hear me now?
Yes, we can.
Okay. Good afternoon, everyone. The president of the society, the chairman of the occasion, our own dear Professor Basson, the Secretary General, and members of mDoc. Thank you very much for the opportunity to speak on the topic given to me, which is how the deadly twin of hypertension and diabetes drive heart failure. I don't have any conflict of interest. This will be the outline of my presentation. We know that hypertensive heart disease is a growing problem worldwide. In a recent publication in Hypertension, it is said that the age standardized worldwide prevalence rate of hypertensive heart disease in 2017 was 217.9 per 100,000 people, which is a 7.4% increase from 1990 data. And then among all the causes of heart failure, hypertensive heart disease accounted for the second highest age standardized prevalence rate of 26.2 in 2017, only second to ischemic heart disease. And because hypertensive heart disease has been identified as an age-related disease, its individual and global disease burden increases with patients and population aging respectively. So the cartoon I've shown here just shows some of the things my colleagues have been talking about, on the problem of hypertension, whether to the brain or to the blood vessels or to the eyes or to the heart and then the kidneys. Now, this cartoon also shows what hypertension does to the heart. Now, the upper panel shows the mechanisms of developing hypertension. We have the demographic factors, the age, gender, obesity, genetics, as well as diet. And there's increase in growth factors, endothelial dysfunction, mitochondrial dysfunction. I have increased preload and afterload, and then increase in sympathetic nervous activity and increase in renin-angiotensin-aldosterone system. All this lead to hypertension. But then hypertension affects the heart in three main pathways. The central pathways is that the hypertension causes myoblast activation, interstitial inflammation, cardiomyocyte hypertrophy, and this leads to interstitial extracellular volume increase, mainly in causes fibrosis and increase in cardiomyocyte volume. This can lead to two things. If we have left ventricular hypertrophy, which will lead to hypertensive heart disease, or you have left ventricular mechanical impairment, or left ventricular diastolic dysfunction, or left atrial dilatation and dysfunction. All this can also lead to hypertensive heart disease. The other pathways at the extreme, you have increase in arterial stiffness and further increase in afterload. And this can also lead to aortic dilatation and atrial wall thickness increase. This will also lead to hypertensive heart disease. And the other side is that there's increase in transmural pressure of all the cardiac chambers. This will lead to increase in left ventricular afterload. And this will also lead to left ventricular hypertrophy and then hypertensive heart disease, including heart failure. Now, this paper was published some years ago showing the 7 pathways in which hypertension progresses to heart failure. Now, the first heart pathway will be hypertension on its own can cause concentric LVH, and they can lead to symptomatic heart failure. Hypertension can either through myocardial infarction or not through myocardial infarction cause reduction in left ventricular ejection fraction, and then you have symptomatic heart failure. And the intermediate pathway will be you have concentric left ventricular hypertrophy. And because of a reduction in blood supply to the myocardium, you may have myocardial ischemia as a pathway, or without myocardial ischemia, it can lead to low ejection fraction, and then patient can still develop symptomatic heart failure. Now, there have been 3 or 4 models that have been developed. In first degree in the progression from hypertension to heart failure, first degree, the first thing that happens is that you have left ventricular diastolic dysfunction. The patient may not have hypertrophy. And then second degree is that patient will have both diastolic dysfunction, you can see the left atrium is dilated there, and then there's increase in the wall of the left ventricle. So there's left ventricular diastolic dysfunction as well as left ventricular hypertrophy. Then the third degree, you can see massive left ventricular hypertrophy. Patient will present with clinical heart failure, and yet the ejection fraction may remain normal, and that is hypertensive heart failure with preserved ejection fraction. Now, the late stage or degree, 4th degree, you can see the myocardium here is burnt out, and then the myocardial contractility is reduced. So, and this kind of geometry, we call it eccentric left ventricular hypertrophy. So patient will have an eccentric left ventricular hypertrophy and then has a reduced left ventricular ejection fraction. Now, relation between diabetes and heart failure. Diabetes is an independent risk factor for heart failure that has been shown by the Framingham study. And elevated blood sugar damages the blood vessels and stiffens the heart muscles. Diabetes increases the risk of heart failure by about 2 to 4 times. On the other hand, heart failure itself can worsen insulin resistance. So the relations, the bidirectional diabetes directly causes structural and electrical changes in the heart, which is diabetic cardiomyopathy, and heart failure can trigger the body to develop insulin resistance, which will worsen blood sugar control. So you have a shared culprit: obesity, high blood pressure, or hypertension, and high cholesterol accelerate the damage in both conditions. And then all these are associated with high mortality. So concurrent diabetes and heart failure result in worse prognosis, higher rates of hospitalization, and greater mortality compared to heart failure alone without diabetes. Now, the third part of this presentation will be the hypertension and diabetes comorbidity and heart failure. Hypertension and diabetes act as a deadly syndemic combination. They work synergistically to damage the blood vessels, they stiffen the heart muscles, they rapidly accelerate the progression to heart failure. It's a vicious cycle. Both conditions can trigger inflammation. They also cause increase in oxidative stress and fibrosis. The hypertension effect forces the heart to pump against greater resistance, which thickens and stiffens the heart muscle over time. And the diabetes directly impairs cardiac cell function and accelerates heart damage independent of the hypertension. And then the combined effects together, they significantly increase the risk of both heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Why the comorbidity is dangerous? When diabetes and hypertension coexist, the risk of cardiovascular mortality and morbidity is compounded far beyond the simple addition of the two separate risks. There is microvascular damage, and there's also macrovascular damage. And this increases the chance of coronary artery disease, which is a leading cause of heart failure. There is kidney complication, there's acceleration of the diabetic nephropathy, and patients are usually in the hospital because these two combined conditions increases the risk of hospitalization. Now, in time, if we look at it, summarizing it with this cartoon, you can see that the common risk factors, insulin-resistant dyslipidemia gene, obesity, they all trigger diabetes and hypertension. And these two can cause atherosclerosis. They can cause endothelial dysfunction. They can cause vascular damage. They can cause vascular fibrosis. They can cause arterial remodeling. Atherosclerosis will give rise to macrovascular complication and then cardiovascular disease. The other parts, endothelial dysfunction, vascular damage, inflammation, vascular fibrosis, they all lead to microvascular disease, which also can lead to cardiovascular disease. This also is another way of looking at it. There's hyperglycemia, activation of RAS, immune activation, oxidative stress, inflammation, and then activation of microRNA. So all this will lead to both micro and macro vascular diseases. And it has been shown eloquently that the more the number of cardiometabolic problems you have, the higher the risk of cardiovascular events. You can see here somebody who doesn't have any comorbidity, and then look at those who have 1, 2, or 3. You can see the hazard ratio increases as we move on, both in all forms of heart failure phenotypes, either heart failure with preserved ejection fraction or in heart failure with reduced ejection fraction. Now, in our local data, what do we have? In the Badon Heart Failure Project, where we have over 2,000 patients, actually 2,061 chronic heart failure patients in our database, recruited between January 1, 2016 up to 31st of December. Hypertension is the most important risk factor identified, which is identified in 73.1%. Diabetes is 13.6%. And if you look at most heart failure publications in Nigeria, it also falls within this range, although we have higher rates in the northern part of the country. And then combined diabetes and hypertension is seen in about 11% of this. This will also be interesting to look at the outcomes of these patients, depending on the number of cardiometabolic risk. So in summarizing, I would say that hypertension and diabetes act as a deadly syndemic combination. They work synergistically to damage blood vessels, to stiffen the heart muscles, and also to accelerate the progression to heart failure through their individual effects on the heart or through their joint effects on the heart. Thank you very much.
Please, let's give him a round of applause. Thank you so much, Professor Oga. We didn't expect less from you. That's a fantastic presentation. You've done a lot of work in that area in past years. Thank you so much. Please, I want to emphasize once again that our speakers should please try and finish up their presentation within the 10-minute limit. We'll really appreciate that. At this point, we'll be taking a break, but in taking a break, we'll be entertaining some questions. Pamela, are you there?
Yes, I'm here. So before the questions, Dr. Fasson, we're going to have an icebreaker just for 5 minutes. And Isaiah, my colleague Isaiah, will be taking that. So over to you, Isaiah. Isaiah, are you there?
He's muted. Can you unmute him, please?
Isaiah, can you hear now?
Yes, I can.
Okay, go for it.
All right. Good afternoon, everybody. It's such a pleasure to have this very session, and thanks to all of our very experts who have made this session so insightful and so comprehensive. We've learned a lot from it. But at this point, it's time to get our body working. We've sat down for the past 1 hour plus, and so let's get some blood pumping so that we do not so that we can have more energy for the second phase of the knowledge you're about to gain. So I'd like to see your cameras on, and then I'd like to see you standing up. And so please, let's have our cameras on, and then let's be up standing. Let's move some blood to our heart and out of our hearts.
Our cameras, we can't videos.
Okay. More cameras, please. Okay, so let's start. So I'd like us to start by shaking our hands. Let's do some shakes. I need to see more cameras, please. And then let's take it up. Let it go up. Okay, so it's time to now move forward. So let's go forward like you want to pick some bags of dollars from the ground. Imagine you have some dollars on the floor and you want to pick them. And then bring it back up. Bring it back up. And then take it backwards like you want to dodge a bullet. Take it backwards like you want to dodge a bullet. Yeah, that works on the waist a little bit. And then take it up again and then shake it a little bit. Shake it a little bit. Okay, it was raining in Abuja recently, so imagine that you are the tree and then there's rainfall and you're moving to the side. So let's move it to the side. The side. Let's move it to the side. Very good. Can you feel it on your ribs? Let's take it back up. Let's take it back up. And then let's go to the other side. The wind is blowing us to the other side now. All right. Okay, and then let's put our hands on our waist and spin it. Let's spin it. Okay. Very, very good. Very good. Let's do some footworks. Let's move our foot up and down, up and down, up and down. Thank you all very much. Let's have our seats.
All done. Great.
Okay, so let's move over to the charts now, where I'd like to let's hear from you one fun thing about you. We have so many people here in different professions and mostly healthcare workers and also professionals in the healthcare space. Let's see one fun thing about you and that you would like to share with us so that we can get to know each other's fun side much, much better. So please, one fun thing about you in the chat room, I'll be checking and I'm giving my feedbacks. Personally, for me, one fun thing about me is the fact that if I come to visit you, most likely I'm going to be having swallow for lunch. So let's hear one fun thing about you that Promise is laughing. If I come to your house and you do not have swallow for lunch, you most likely will not be my very good friend. And preferably pounded yam. Okay, so let's hear. I'm in the chat room and I'm looking at your messages. or myths or facts. I'm seeing Kendi saying the serious predisposed children. Oh, okay, that's a question. So I'm waiting for, somebody said water is the best drink. This person must be good with water. I remember growing up and I remember somebody giving me about 2 jugs of water and I couldn't sleep anymore. So I'm trying to agree with this, but water is actually a very good thing. Somebody said he loves kusum aya. And another person said, I start dancing when I hear music. I'm sure you dance to the music that we played when we started the program today. And it Spencer, I love listening. Ogugua Osiobu says, I love listening to music. Music is everything. It's a healer. And it's fun fact about me is I love playing football. That is a good exercise. It helps the heart and it helps the body to stay fit. Somebody said I would drink kuli kuli.
The president says he will give you Gary and Kuli Kuli when you visit him.
I will come with my milk. I will come with my milk and my water. Thank you very much, Professor Simon Isezo, for that. Somebody says if you have Uwemi Bimbok Ekanem says if you are 40 years and above, I don't serve you soda drinks in my office. I serve water. That is awesome. Water is a total package and it contains a lot more than soft drinks will. I think that's a good plan to follow. Please keep them coming. Fun fact about me, I can't go to my hometown on my own as I don't even know the way to get there. This is what globalization is doing for us. Okay, but next time you're going, please, I would love to share my Google Map with you so you can use it. I'm sure Google Map can take us anywhere we want to go to. That is beautiful. And then the other one says, I love AI stories on YouTube. I'm a fan of that. I love animations a lot. I watch them a lot more.
Someone is an Arsenal fan here.
I love watching national ball. we have an Arsenal fan in the building, and they are taking the trophies in this season. And then I have another person here who says, I love swimming. Swimming is a life skill, and everybody should learn that. I'm still midway into learning swimming, so I'm definitely joining you. Let's see who gets to the finish line first. My fun fact is music and dancing. Music is good to the body, and music is good for the mind, and then dancing is good for the body. Hot bit-sized akara is staple in my home. I do that every Saturday, and I do it with pap. I'm sure somebody else might like it with bread or something, but it's a very good African meal, and I love it too as well. Fun fact, I love swimming. Swimming is a good skill. Thank you for sharing that, Oluwakemi Obunaye. I'm a great dancer sitting, but turns to rubbish once I stand. Oh yeah, some of us know how to dance better when we are sitting down. We are together. We are together. So don't think too far. We are together. And then somebody say, I love walking. Taking strolls are wonderful. I'm a great dancer, sitting, but turns to, okay, I think I've already read that already. Mohammed Gali Musa said, I love walking. Yeah, walking is good. I love singing and empowering young women. That is beautiful. That is a sustainable long-term impact that you will see in the future. Success Onyenikiwe says, I love dancing, but I'm not a good dancer. And everyone thinks I can dance very well because I look like someone that can dance. So if you look like someone that can dance, it means you can dance. So maybe you can as well just learn the skill. Okay, thank you, Success, for that. Peace says, I'm a fellow chair dancer. We are together. We are very much together. There are a lot of us that know how to dance on the chair.
Thank you so much, Isaiah. I think we need to
All
move
right,
on
thank
now.
you all so much for your comments.
Yes.
We really appreciate those. Thank you very, very much.
Thank you. So back to you, Dr. Fasson, for the next bit.
Okay, thank you so much. I would love to acknowledge some of our elders who are on this platform. I could see Professor Ajulu Chukwu seated somewhere there in our room, in our sitting room, and a few other people which we will name as we go ahead. So we will just pick up a few questions and so that we can move on to the next phase. I can't see too many questions addressing individuals, but they are like general questions. So someone says, Emmanuel Onogu says, What blood pressure targets should we emphasize for different age groups? How much impact can stress management have on blood pressure control? What blood pressure targets should we emphasize for different age groups? How much impact can stress management have on blood pressure control? Professor Oga, would you like to take that? Professor Oga? Okay. Well, I guess anyone can take it if he's having troubles with the network. Professor Manven, Professor Abaka, Professor Loco. Am I audible, please?
Yes, you are.
Okay.
Sorry, Dr. Fasan, what was the question about BP targets again?
Yes. Well, it says, what blood pressure targets should we emphasize for different age groups? How much impact can stress management have on blood pressure control?
Well, I'm not the expert in BP control, but I know I treat a substantial number of persons with elevated blood pressure on a daily basis. The recommendation from the American Diabetes Association is 130/80. But we know in the past, there was recommendation that blood pressure in people with renal disease should be lower to 120/75. But that has changed remarkably because it's counterproductive to lower blood pressures. Whether you have to lower blood pressure based on age group is difficult for me to answer. Maybe when Oga comes back to the call, he will be able to speak to that. But it's a general consideration that we like to keep blood pressure 130/80 as optimum as much as possible. The impact of stress management and BP control. Yes. In numerical terms, I will not be able to give you figures, but if you are able to manage stress very well, it is well established that the BP elevations that you see will be greatly minimized. But as to what proportion of or how you measure the impact of stress management, how you quantify it to translate to BP management is difficult to say. But it goes without saying that stress is a well-recognized risk factor for BP elevation and even other cardiometabolic risk, like we have always maintained, and it should be managed as much as it is possible. Thank you.
Thank you, Prof.
Let me just add with regards to blood pressure targets in a CKD patient, because our latest KDICO 2024 guideline, recommended that less than 120/80 millimeters for most adults with CKD, as Professor Loco has said, but it's very aggressive. So the goal is to slow down the progression and to reduce the cardiovascular. Then, of course, for older adults, frail adults, greater than 80 years, it suggests that you should individualize the targets because of the weakness. So at least less than 120/80, is the goal for us. But of course, depending on the situation and what the person has, maybe if he has albuminuria, if they have other comorbidities.
Thank you so much. I can say that. Okay, Prof, go ahead, sir, the president.
Yes, I'm not sure whether Professor Oga is still around. So, but what I would just say is that with regards to blood pressure target according to age, for adults age 18 years and above, if you recall, it is only JNC that set up a target of 140, below 140/90 for those between 18 and 59 years. And then another minority report, which was very controversial from ANC, that stipulated 150/90 for those who are 60 years and above. So apart from this, all the other guidelines don't set up different targets, for adults with hypertension for age 18 years and above. And so let me just use this opportunity. I saw a question 2 on the chat, and I think it's an experience I have also seen before. I don't know whether Professor Abubakar is still on the call. For patients who have hypertension and diabetes, despite control of both blood pressure and blood sugar, still having stroke. What could be the explanation?
I'm still on the call, sir.
Yes.
Usually, yeah, in the evolution of a stroke, there are so many factors that actually come together. The fact that the person is hypertensive and maybe it's not well controlled, looking at those mechanisms of evolution, there's atherosclerosis, even if the pressure is controlled, and those atherosclerotic changes could result in the deposition of fibrins, and the vessels can actually be risk of thrombus formation, and this thrombosis can actually embolize to have arterial embolism, which could result in infarction. And again, the slow progressive damage to the vascular endothelium could result in stroke, irrespective of what the pressure is. And that is why in individuals, even if they are not hypertensive or diabetic, as the age advances, they could also be at the risk of stroke. So controlling the blood pressure and diabetes, agreed, it lowers the risk of lipohydrosis and microarrhythmia, but the risk is still there. So, and in evolution of stroke, many factors actually come together. That's why I want to talk about cause of stroke. We talk about risk factor profile. Those risk factors actually come together. So it's difficult for one to say it is hypertension, it is diabetic, both just synergistic. Age is also there, and ethnicity also come into play. So those are the factors. It's multifactorial if we look at it. Thank you very much, sir.
Thank you so much, Professor Abubakar. Just to add that the concept of this defining blood pressure targets in recent publications of European Society guidelines, the concept of the ALARA principle came up. If you all know, ALARA principle is the as low as reasonably allowed. And this comes in older people who might not be able to tolerate the targets that we've set. Sometimes the targets might be, a number of us try to drive as low as 120, between 120 and 129. Some people might not be able to tolerate that. So you have to be careful to understand that you take it to as low as reasonably allowed for the particular age of the patient. So when they start having symptoms of postural hypertension, then you have to stop it there. Professor Dr. Osiobu, are you still there?
Before she comes on, let me just quickly add that the concept of metabolic memory is also important in patients who develop stroke despite adequate control of blood glucose and probably high blood pressure. Metabolic memory in the sense that in the days when there is poor diabetes control and the damages have taken effect, for a prolonged period of time, duration has a factor in it. Even if later there is control of diabetes and high blood pressure, it is possible that damage that was done there existed and confers some measurable amount of risk for developing stroke. Nonetheless, that you are now well controlled. So the concept of if you know about positive legacy effect deriving from metabolic memory, there is also a negative legacy effect, in which case a patient develops a cardiovascular disease, even though too late a control has been achieved. But that is to be determined to what extent. Thank
Okay,
you.
thank you. I think we will hold the questions now. We still have more time at the end. We need to go to the second phase now. Dr. Subu, sorry, you probably will have your time later. Apologies. So I'll move on to Professor Felicia Anuma. She's a professor of medicine. She's an endocrinologist and diabetologist at the University of Abuja, and she's also a honorary consultant to the University of Abuja Teaching Hospital. She is the director of the Center for Diabetes Studies and editor-in-chief of the African Journal of Endocrinology and Metabolism, AJEM. She's a leading voice in diabetes care and non-communicable diseases prevention in Nigeria. Her work focuses on diabetes prevention, diabetic foot disease, obesity prevention, and community-based care models. She currently serves as president of the Diabetic Foot Nigeria Initiative, DFNI. The next person is Professor Kamilu Musa Karaye, a professor of medicine at Bayero University, Kano, and consultant cardiologist at the Aminu Kano Teaching Hospital, Kano. She currently serves as Dean of the Faculty of Clinical Sciences and acting provost of the College of Health Sciences at Bayero University. He is a globally recognized cardiovascular researcher. He leads multiple national and international cardiology studies and has published over 140 peer-reviewed papers in cardiology and internal medicine. And then I have Professor D.K. Oji. Professor Oji is a faculty member at the College of Health Sciences, University of Abuja, an honorary consultant, physician, and cardiologist at the University of Abuja Teaching Hospital. He completed his medical training at the University of Ibadan and further specialized in internal medicine and cardiology at University College Hospital Ibadan and the Royal Brisbane and Women's Hospital, Australia. He is a respected cardiovascular researcher and clinician. He holds a PhD in cardiovascular medicine from the University of Cape Town and has published over 66 peer-reviewed manuscripts in leading journals, including New England Journal of Medicine and JAMA, the Lancet, and European Heart Journal. His research focuses on hypertension, hypertensive heart disease, and heart failure in African studies, in African populations. At this point, I would like to welcome Professor Felicia Anuma, who will be talking about screening, early detection, and management of diabetes and hypertension. You have the floor, ma'am.
Okay. Can you hear me? Can you hear me?
Yes, we can, ma.
Okay. Okay. Thank you very much. Good afternoon, everyone. I want to thank the Hypertension Society of Nigeria and mDoc for asking me to give this talk on screening, early detection, and management of diabetes in hypertension. We all know what diabetes, a group of metabolic disorders characterized by hyperglycemia, is one of the greatest epidemic of the 21st century. And as far back as 2009, WHO had said that globally, high blood glucose is the third highest risk factor for premature mortality after high blood pressure and tobacco use. Of course, we know we have different types of diabetes. Type 1 is a disease that is thought to occur when the body's immune system destroys the cells in the pancreas. And type 2 is a disease that occurs when the body does not make enough insulin or does not properly use the insulin it makes. And type 2 diabetes accounts for 90% of diabetes cases. Sorry, I think this is the wrong slide though. The reduced slide is not the one I have. You are showing now. Dr. Fasson. Dr. Fasson. Please, this is not the most recent slide, presentation slides that I sent.
Can you share your slides yourself?
Okay, let me share my slide, please. Allow me share my slide. So you can close up this. Let me share my slide. Okay. So have you given me permission to share?
I'm sure they are working on that now.
Okay.
I believe you can share, Professor
Okay.
Anuma.
Okay. Are you sure you have allowed me to share?
Yes, we have.
Sure. Well, I sent the slides to Dr. Fasson, so if you can get it from there, because I'm not able to share from here.
Roderick, can you do that, please? Can you check is with you now?
Sorry?
Yes, sir. It's coming up.
Yeah, because I can't share from here.
It will
I'm
be
not
shared.
allowed
It will
to
be
share.
shared. It will be shared now. Just hold on.
Okay, okay, okay. Okay. So, so let's go backwards. Backwards, please. Okay, we can continue from here. So, type 2 diabetes is a complex metabolic disorder with insulin resistance and insulin deficiency, has social, behavioral, and environmental risk factors, unmasking the effects of genetic susceptibility. And type 2 diabetes accounts for 90% of diabetes cases. Next one. Okay, so we need to look at risk factors when we are talking about screening. So early screening and early diagnosis, we need to look at risk factors. So non-modifiable risk factors, which you are familiar with, of course, age, more than 35 years, people need to begin to look at their blood sugar, race, blacks are more predisposed, and then family history is important. Sorry, back, please. Back. Okay, so modifiable risk factors, of course, include diet, physical inactivity, obesity, tobacco use, pre-diabetes, gestational diabetes, fetal macrosomia, and multiparity. Next one. Others include heart disease, hypertension, low HDL and high triglyceride, polyendocrine metabolic ovary syndrome, what we used to call PCOS, and antiretroviral therapy, new antipsychotic treatment, and fatty liver disease. Now, dietary factors as independent risk factors. We need to look at the characteristics of fat intake, whole grain, cereal fibers, dairy products, the glycemic load, glycemic index of the meal, Western diet, food, fast food intake, which we love so much in Nigeria, soda intake, alcohol intake, and red processed meat. Then we have emerging risk factors, psychosocial factors like stress, depression, anxiety. Somebody was asking a question earlier, if stress is reduced, if it will help. Sorry, please, in the prevention of hypertension or diabetes. Then gut metagenome, gut dysbiosis, hostile gut environment, and increased membrane transport of sugars, vitamin D deficiency, and vitamin K1 deficiency. These are emerging risk factors. Now, this is the natural history of disease progression, and it's important here for us to note that about 10 years before, we already have problems with insulin resistance, as you can see, and of course, subsequently, B-cell dysfunction. This is what we call the pre-diabetes state, which is very important, because if we're able to catch patients or individuals at this stage, we can institute measures to prevent them getting diabetic. And what is also very important here is that you can see that years before the actual diagnosis of diabetes, macrovascular complications, start, and then subsequently followed by microvascular complications. This is the reason why you may be diagnosing a patient diabetic today, but that patient already has chronic complications of diabetes. Next one. Now, this is the Finnish Diabetes Association risk score tool that we can use actually to assess individuals for their risk for diabetes. And like I said, we can institute measures depending on the risks they have to prevent them from getting, frankly, diabetic. Next one. Next. Okay, so screening and diagnosis of diabetes. For the diagnosis of diabetes, A1C greater or equal to 6.5%, we should have a confirmation on the second occasion. Fasting blood glucose 7 millimoles per liter and above, it should also be confirmed on the second occasion. And then blood glucose 11.1 at 2 hours after oral glucose load, we should also have a confirmation on the second occasion. And then random blood glucose 11.1 and above in a patient with classical symptoms of hyperglycemia or in a hyperglycemic state. Now, for the diagnosis of prediabetes in a non-pregnant individual, A1C 5.7 to 6.4, fasting plasma glucose 5.6 to 6.9. This is what we call impaired fasting glucose, and the 2-hour plasma glucose post OGTT 7.8 to 11. This is what we call IGT. And these are the two categories in prediabetes, very important to us because in our setting, prevention is better than allowing the patient to get there with all the complications that is so expensive to manage. So how common is hypertension in diabetes? In type 1 DM, nephropathy is the major driving factor. The prevalence increases with increasing degree of albuminuria. 19% in no albuminuria, 30% in moderately increased albuminuria, and 65% in severely increased albuminuria. In type 2 DM, elevation in blood pressure occurs before the onset of moderately increased albuminuria. Strong correlation with obesity. Sorry, please, back. There's a strong correlation with obesity, and 50 to 80% of patients with type 2 diabetes have hypertension. Type 2 DM is 2.5 times more likely in patients with hypertension. Now, I did a diabetes prevention study in 20 secondary schools in the FCT, and I worked with 3,000 children. And what we discovered is that about 32.9% of these children were either overweight or obese, and this generation, the generation of children with overweight and obesity, they are the very next generation of people with diabetes and hypertension. That's a time bomb that is waiting to explode. And when we looked at those who have risk factors and we screened them for diabetes, we found pre-diabetes in 23% of these children. Now, treatment goals for hypertension in diabetes. Blood pressure targets should be individualized. The process must address cardiovascular risk, as we have been hearing since the beginning of this presentation, potential adverse effects of medications, and of course, individual preference. The treatment target of BP, please, I've not finished. Please, let me go back to the previous slide. The treatment target BP goal is less than 130/80 if it can be safely attained. And in pregnant persons with DM and chronic hypertension, a BP threshold of 140/90 for initiation or titration of therapy is associated with better pregnancy outcomes. And therapy de-intensified for BP less than 90/60, like we had mentioned earlier, a BP target of 110 to 130/85 is suggested to decrease the risk for accelerated maternal hypertension. Now, this guideline looks crowded, but is the ADA guideline on managing blood glucose levels, and with particular attention to patients who have atherosclerotic cardiovascular disease, those who have heart failure, those who have CKD. And drugs like GLP-1 analogs and SGLT2 have been found to be very beneficial in this group of individuals. And then when weight consideration is important, because we know that excess weight is counterproductive in the management of diabetes and even hypertension. So drugs like metformin and GLP-1 analogs have come very handy. And then next slide. When we don't have target glycemic control, we can add basal insulin. And depending on how the control becomes, if we're still not at target, we can think of using basal bolus insulin therapy for these patients, particularly when we find the ones that are very well motivated, and we can combine GLP-1 analog and insulin therapy. SGLT2 and insulin therapy. Now, this is just a guide to show us the various classes of drugs we have in managing diabetes, the efficacy of these drugs, their tendency for hypoglycemia, cardiovascular effects, renal effects, and of course, cost that is so important and such an important consideration in our environment. Thank you very much. I hope I kept to time.
Thank you, ma. Please, let's give Professor Anuma a round of applause. That's a fantastic presentation. Thank you again. I'll move straight ahead and introduce our next speaker. Our next speaker is Professor Kamilu Karaye. He will be talking on early detection and management of hypertension in diabetes.
Can you hear me?
Yes, we can.
Okay,
You need to put it in slide mode, please.
Okay, so
presentation mode, yeah.
okay, thank you very much for the introduction. The chairman for this occasion, Emeritus Professor Obasanjo, the president of Nigerian Hypertension Society, Professor Isezuo, distinguished panelists, distinguished colleagues, ladies and gentlemen. Thank you very much for the kind invitation to present, and the title of my talk is Screening, Early Detection and Management of Hypertension in Diabetic Patients. I'll be following this outline, starting with an introduction. The age-adjusted prevalence of hypertension among adults in Nigeria was estimated at 36%, while that of diabetes was estimated at 3.7%, at least as presented in the most recent demographic and health survey for Nigeria, which was published in September last year. And these figures seem to me to be the official figures recognized by the Federal Ministry of Health. Among those aged between 15 and 49 years, as you can see on this slide, the level of awareness for hypertension and for diabetes are very, very low, just about 5% in men and 8% in women, while that of blood sugar is just about 1%. And among those who have been informed that they have these two conditions, the percentage taking medications are somewhere around 40 to 50%. So you agree with me that these are very critically low percentages. Hypertension is more common in patients with diabetes than in the general population, and this has been repeated in this seminar. Likewise, the opposite is also true. So there is what you can describe as a chicken and egg relationship between hypertension and diabetes, and it seems that insulin resistance is playing an important role in the pathogenesis of hypertension. This is shown in this slide, in this cartoon. Insulin resistance and diabetes lead to an activated renin-angiotensin-aldosterone system and sympathetic nervous system, leading to mitochondrial dysfunction and oxidative stress and inflammation, and ultimately leading to vascular stiffening and hypertension. Likewise, the two conditions, insulin resistance and diabetes, lead to abnormal release of extracellular vesicles and microRNAs, leading to dysfunctional gut microbiota, ultimately leading to sodium retention, vascular stiffening, and hypertension. And you can see that the arrows are also going backwards. So hypertension itself can predispose backwards to lead to insulin resistance and somehow to diabetes mellitus. Framingham data show clearly that coexistence of hypertension and diabetes significantly increases the rates of all-cause mortality and cardiovascular disease events compared with normotensive persons with diabetes. And this is the data from Framingham. It shows that the population attributable risk from hypertension in subjects with diabetes was 30% for all-cause death and 25% for any CVD event. In comparison, the population attributable risk for diabetes was 7% for all-cause mortality and 9% for any CVD event. And therefore, the authors concluded that although diabetes is associated with increased risk of death and cardiovascular disease events in Framingham subjects, much of the excess risk is actually attributable to coexistent hypertension. Now, one of the, let me say, contentious issues or uncertain issues is the level of blood pressures and outcomes in type 2 diabetic patients. So despite mounting clinical evidence supporting the benefits of BP reduction, the optimal BP target for patients with diabetes was uncertain. This is a very recent paper published this year on the dose-response meta-analysis of blood pressure levels and outcomes in type 2 DM. And the aim was to examine the risk patterns of major clinical outcomes across a wide range of BP levels in participants with diabetes. And I think this is one of the questions asked during the Q&A. And the results show that in this population of over 5.8 million people, the relationship between systolic blood pressure and risks of primary outcomes, that is cardiovascular events, and also all-cause mortality was rather J-shaped, while that of diastolic blood pressure and cardiovascular events and all-cause mortality was also J-shaped. But that of systolic and diastolic blood pressures and renal events is rather more linear. And you see that the deflection point, the point of deflection is 120 millimeters of mercury for systolic and 80 millimeters of mercury for the diastolic blood pressure. And therefore, in type 2 DM, BP is linearly associated with most cardiovascular and renal outcomes. And in fact, the data shows that low SBP systolic blood pressure does not appear to be associated with an increased or elevated risk of all-cause mortality compared with higher BP targets. But of course, this has to be interpreted with some level of caution. Now, the American Diabetes Association Professional Practice Committee advocates that multifactorial approach to reduction in risk of diabetes complications should be adopted, should be encouraged. And the foundation for this is lifestyle modification and diabetes education. And there are 4 pillars: glycemic management, blood pressure management, lipid management, and use of agents with cardiovascular and kidney benefit. Of course, our main discussion today focuses on blood pressure management. The ADA, concerning screening and diagnosis of hypertension in diabetic patients, the ADA, that's American Diabetes Association, recommends as follows. Some of these have already been mentioned by Professor Anuma. BP levels should be measured at every routine clinical visit, or at least every 6 months. This is very important, and this calls for, a change in attitude in our clinics. There is no need for us to be separating hypertension and diabetic clinics, really, as already mentioned or suggested by the president. Because blood pressures are critical. Very high blood pressures are critical to control of diabetic complications. Individuals found to have elevated BP, even without a diagnosis of hypertension, should have blood pressure confirmed using multiple readings, including measurements on a separate day to diagnose hypertension. Importantly, regular blood pressure screening can facilitate early diagnosis and reduce the risk of complications associated with hypertension. Hypertension in itself is defined as, in diabetic patients, as a systolic blood pressure of 130 millimeters of mercury or higher, and/or diastolic of 80 or higher, based on an average of 2 or more measurements obtained on 2 or more occasions. Individuals with severely elevated blood pressure and cardiovascular disease need not to have repeated measurements. We should counsel all diabetic patients with hypertension to monitor their BP at home after appropriate education. On the BP treatment goals, the ADA recommends that for people with diabetes and hypertension, blood pressure goals should be individualized through a shared decision-making process. So patients should be involved in the decision-making. And if it can be safely attained, the on-treatment BP goal should be below 160, 130 systolic and below 80 diastolic. But a systolic BP goal below 120 millimeters of mercury should be encouraged in individuals with high cardiovascular or kidney risk. And we have seen this in the meta-analysis I just shared, which was published just a few weeks ago. Now, on the recommendations for treatment of confirmed hypertension in non-pregnant people with diabetes, the ADA recommends that we need to ensure that patients adopt healthy lifestyles for all patients. And then for those with blood pressure systolic below 150 and below 90, diastolic below 90, at presentation, we may start with one agent. And this agent, before we decide, we need to also consider presence or absence of albuminuria or coronary artery disease. For those with higher blood pressures, we may start with two agents and also take into cognizance presence or absence of albuminuria or coronary artery disease. And then we can add on to either ACE inhibitors or ARBs. We can add on to these calcium channel blockers or diuretics. And whenever there is difficulty in control, we may add a third agent from this group. And then ultimately, you can also consider addition of a mineralocorticoid receptor antagonist, and then, if need be, even referral to an expert on blood pressure management. And this is the algorithm proposed by the ADA. The ESC guidelines, 2024 ESC guidelines for the management of elevated blood pressure spoke the same language, or speaks the same language, basically the same recommendations, no much difference. We need to appreciate the first point that in most adults with elevated BP and diabetes, after a maximum of 3 months of lifestyle intervention, blood pressure lowering with pharmacological treatment is recommended for those with confirmed office BP of as above the cutoff to reduce CVD risk. So we need not to continue to observe. We need to begin to intervene with pharmacologic agents after 3 months. So I have only 10 minutes, so I would like to summarize as follows. Prevalence of hypertension in Nigeria is approximately 36%, and also for diabetes about 3.7%, at least as presented in the most recent data from Federal Ministry of Health. The level of awareness of hypertension and diabetes in the general population are critically low. I need to also mention that the approximate prevalence of hypertension in Nigeria is above the global average. For males is about 34%, and for females is about 32%, while that of diabetes is clearly lower than the global average of 14%. Hypertension is more common in patients with diabetes than in the general population, and vice versa. And then we also need to appreciate that although diabetes is associated with increased risk of death and CVD events, much of the excess risk is attributable to coexistent hypertension. And we have seen that in type 2 DM, BP is linearly associated with most cardiovascular and renal outcomes. We have also seen that we should be monitoring the BP very closely in hypertensive in diabetic patients, and therefore we may not even separate the two clinics. We should counsel all people with hypertension and diabetes to monitor their BP at home. And then we need to regularly screen BP in diabetic patients, because it can facilitate early diagnosis and reduce the risk of complications associated with hypertension. I think that is the last point. Thank you very much.
Thank you, Professor Karaye. That's a fantastic presentation. Thank you so much. Thank you to us also for keeping to time. We didn't expect less from you. Thank you so much. I'll be introducing Professor Oji. Please permit me to read the citation again. Professor Oji is the Professor of Medicine and Preventive Cardiology and Head of Internal Medicine at the College of Health Sciences, University of Abuja. He's the lead investigator of the Cardiovascular Research Center and also the Director, Institute for Advanced Medical Research and Training at the same university. He holds an honorary visiting professorship to the Cape Heart Institute, University of Cape Town, South Africa. He has well over 300 publications, and his research areas focus on improving cardiovascular care in low and middle income countries, particularly among Black populations, and spans hypertensive heart disease, optimizing hypertension pharmacotherapy, and developing primary care systems for hypertension and cardiovascular management. Please, let's welcome Professor D.K. Orji. Professor Orji, you have the floor, sir.
Right.
Unmute yourself. Okay, great. Go ahead, sir.
Can you hear me?
Yes,
Hello?
we can. We can hear you, sir.
Okay, thank you very much. Please, I will put off my video so I can maximize the bandwidth. Yeah, good evening, sir. The chairman of this occasion, Emeritus Professor Obasa. Also, good evening to the president of the Nigerian Hypertension Society, Professor Sezo, and also to my senior colleagues, distinguished colleagues, ladies and gentlemen. So my talk is tax shifting, choose and nurses-led hypertension and diabetes clinics. We all know that NCD is ravaging the world, and leading that pack of NCDs is actually cardiovascular diseases, apart from the cancers. And the number one risk factor for cardiovascular disease is high blood pressure. You can see from our data here, the prevalence of hypertension in Nigeria is put at about 31.1%, whereas diabetes, which often coexists with hypertension, as we have seen in our earlier talks, is about 5.8%. Like I said earlier, we all know that hypertension coexists with diabetes. In our Abuja Heart study, we found that about 8.4% of our hypertensive patients, over 2,000 of them, also had coexisting diabetes. Because of the burden of hypertension and diabetes worldwide, the WHO in 2016
Professor Orji, can you hear us? You're breaking. Professor Orji?
Maybe you can share his slides. But we can't hear.
We can share his slides, but we still can't hear him.
Yeah, that's true.
Professor Orji, can you hear us? Dr. Fasson?
It's raining. So maybe.
Okay. Dr. Fasson, can you hear us?
Yes, I can hear you.
Hear you now.
Okay.
It's raining heavily here. Sorry, the
Okay.
network is
back.
Sorry. So I was talking about the arts package that H standing for healthy living, E for evidence-based therapy and technology, that A stands for access to generic medication, R stands for risk-based care, T standing for team-based care, and S standing for a system for surveillance, which is represented here. You know, if you look at your left, that is a simplified protocol, you know, talking about having technology, having materials that can help care. Then you talk about medication. For generic medication, it's a team-based care, not only physician-centered, but it's a team-based care. Then we talk about having instruments or technology, like having a blood pressure measurement at home, and then a system for information. or dissemination, able to recall the patient back to the clinics. Now, for the arts package to be well executed, we need a tax shifting and tax sharing policy. And I think this is one of the best things that has happened to our country in order to reduce cardiovascular disease risk and then also cardiovascular disease. So we now have a policy that allows non-physicians, especially nurses, and also community extension workers to be able to initiate therapy for uncomplicated hypertension and uncomplicated diabetes, provided it is under strict monitoring. So in 2019, we started a program which we call the Hypertension Treatment in Nigerian Program. That program is actually to establish a system for hypertension management in 60 primary healthcare facilities in the Federal Capital Territory of Nigeria. And it is based on the WHO Act, which I've described before, and the Kaiser Permanente Northern California model. The Kaiser Permanente Northern California model is one of the most effective models that has worked globally, because over a 10-year period, blood pressure control increased from 44% to about 90%, and it remains so for a very long time. So based on this, we started a program, and we have our strategies for that program. One, using a standard treatment protocol, a very simple algorithm that non-physician healthcare workers can use, patient registration and empanelment, making sure that the patients are registered in those primary healthcare facilities to have their blood pressure checked as much as possible, prioritization of fixed dose combination where available, then team-based care, which I've described before, and also empowering the patient to be able to measure their blood pressure back then at home. So after a 3-year period, we succeeded in having blood pressure control move from about 22% to about 57%. That was our story there. And like I said earlier, this was in 60 primary healthcare facilities. There were some facilities that control rose to about 70%, and also some facilities that have control maybe just below that, maybe about 55%. But on the average, we had our control in these 60 primary healthcare facilities increased to 57%, as I said earlier. My slides are not moving very well. Okay, so what are some of the factors that contributed to improve blood pressure control? Training and retraining. Now, within this period, we trained over 525 non-physician health workers, including community nurses, community health extension workers, pharmacists and pharmacy technicians, record information officers, health educators, and also other cadres of workers that we're going to support in the management of this patient. Now, we had over 74 didactic training sessions. Apart from training them on site when we do our monitoring visit, we had what we call quarterly supportive supervision. We had over 680 quarterly supportive supervision. So our team comprised a primary care community physician going, a nurse going with them, a pharmacist, and also like a record officer or research assistant going with them to ensure data quality. Then there are community awareness campaigns. We have over 207 community awareness campaigns led by our team, and we reach out to over 6,500 attendees in those campaigns. Then another good thing was that we were able to maintain drug revolving fund after the free drug period, was exhausted. We have also integrated hypertension into HIV care. People living with HIV are living longer now because of greater access to very active antiretroviral therapies. And because of that, these people are dying from heart failure, from stroke, and chronic kidney disease, and are being spared from the more traditional complications we're seeing, with HIV, like the Kaposi sarcoma and the tumors and so on. And so we did this, and this was in Akwa Ibom State. The slide is not moving, but I'm trying to move it. And after our intervention, we use what we call a step wedge. It's about a bit of a complex design system. So our intervention for each of the patients was for about 12-month period. And what we saw was that there was a drop in systolic blood pressure from about 154, 155 to about 125. That was a massive drop. And this was sustained even after our intervention in 12 months. Over the 18 months period, as you can see from this figure. So next is diabetes. So the HEART package, when it was first developed, centered around hypertension. But later, WHO then moved on to include diabetes. That is why you now have the ASD. So, and to test this, we started some work in 10 primary healthcare facilities. Out of the 60, we have integrated hypertension into. And our focus actually has been around screening. So I'm trying to move the slide. Our focus actually has been around screening these individuals. So one, being able to get people to get their blood pressure screened using a glucometer. And in some cases, we also had them to have their glycated hemoglobin, checked. So we have the staff there, we train, we have our research staff going there to train these people. And after about 3 months period, we have been able to screen over 2,000 people. Trying to get to my next slide. Trying to screen over 2,000 people. And out of these 2,000 people, it's jumped now. The previous slide. So if you can get to the previous slide. Okay, good. Yeah. Anyhow, we've been able to screen over 2,000 people. And out of these 2,000 people, we found out that about 8.7% of them, have high blood sugar, either using a fasting blood sugar or using glycated hemoglobin. Still not moving. I think it's in the network. Sorry, almost at the end. Okay, good. Now, but before that time, we had a pilot study, and that pilot study was in 2 primary healthcare facilities, also in the FCT. And over a 3-month period, in those facilities, we had 160 diabetic participants. Now you can see their profile there. Middle age, about 53 years. You can see the more female compared to male. Never attended school, was about 5%. And you can see a proportion of them had hypertension as expected, about 37%. You can milligrams per dl. Sorry. Yeah, there's another slide that I did not show, I'm sure because of the network, but then over that period, a number of the patients were commenced on anti-diabetic agents or anti-hyperglycemic agents. There was a they succeeded in reducing control by about 25% if you use glycated hemoglobin and by 15% if you measure by fasting blood sugar. Now, so in conclusion, to tackle the high burden of hypertension and diabetes mellitus in Nigeria, there's the need for a healthcare approach that a health organization has technical package. Such an approach leads to early detection of hypertension and diabetes mellitus, improvement in primary prevention, and therefore very highly cost effective. Thank you very much.
Thank you,
Sorry
Professor.
for the technical hitch.
Yeah, we understand. We are also sorry for the mix-up initially. We had earlier said that you had 66 66 papers, publications, but it turns out that we are far behind from where you are now. So over 300 papers, publications in international journals, peer-reviewed. Thank you so much. That was fantastic. I can see Malau there. Malau, well, thank you for being with us since. He's from the NCD desk of the Federal Ministry of Health. Okay, I think at this point, Pamela.
Yes, Dr. Fasson. So we'll take some questions, maybe like 3 questions max, because we're already gone over time. So we'll have time for the post quiz and then for your closing remarks. So if we can take 2 or 3 questions, that would be great.
Okay.
So
someone
over
says,
to you.
Thank you. Someone says, is there a place for pharmacologic therapy in management of prediabetes that is refractory to lifestyle modification? I think Professor Anuma will take that.
Yeah, I will take that.
Go ahead, ma'am.
Oh, I should go ahead. Okay. Okay, of course, yes, there is. I mean, there are studies that have been done. The Finnish diabetes prevention study, the diabetes prevention work in the US and in China, they have proven that if we catch patients in the pre-diabetes state and we institute lifestyle measures and they are not, we are not achieving what we want, they can actually benefit from metformin. So there is a place for pharmacotherapy in pre-diabetes state.
Thank you, ma'am. I want to just read out a statement by Dr. Subu, who is the subspecialty chair of geriatrics in West Africa College. She says, I wanted to reiterate the need to personalize care in older persons. This is in relation to the story of the hypertension question that was asked earlier. I wanted to reiterate the need to personalize care in older persons, in acknowledgement of the heterogeneity of the cohort of older persons, so 60 years and over. Blood pressure targets must be individualized. Avoid intense control in frail older adults to reduce the risk of adverse effects such as falls, worsening cognitive function, etc. Dr. Fatson, thanks for bringing up the ALARA concept, critical in managing geriatric patients. Let's remember that there is an increase as a risk factor for all the chronic CV conditions we are discussing today. Attention as a risk factor. Thank you, Dr. Siobu.
Dr. Fasson, please, can I make a comment there? Can I make a comment, please?
Okay, ma'am, go ahead.
Okay, so also in diabetes, it is individualized. When we get younger people less than 60, we are very strict as far as, what the targets are. But in elderly people, those more than 60, we are not as strict because we know the negative impact of hypoglycemia in them, particularly when they for the heart. If they have ischemic heart disease and you allow hypoglycemia, it will worsen it. It will also cause dementia, for them. So we also individualize and we are not as strict in the elderly. Thank you.
Thank you so much. Professor Sezu, you wanted to say something?
Yes, thank you very much. I want to thank the presenters in this second section for a beautiful presentations. I don't know whether any of them or at least Professor, the 3 of them will make brief comment on feasibility of integrated management of hypertension and diabetes.
Well, can I make a comment?
Go ahead, ma'am.
Okay. Well, like we have heard in all the presentation, most of the presentations, 50 to 80% of our patients, of our diabetes patients are hypertensive. And so we have been managing them, along that way. Yes, it will be a beautiful thing for us to have some multidisciplinary or collaborative management, but the restriction is the time. if we are going to have a separate clinic for diabetes, hypertension, it's almost like the diabetes patients at the same time. Because like I said, 70 to 80% are hypertensives, and we manage their blood pressure and their blood sugars together.
Okay, ma'am. Thank you so much. Etiobong Etukumana, can you unmute and make your comment briefly or questions?
Yeah, okay. All right. Thank you very much. I've been enjoying your presentation, and it's quite. Are you hearing me?
Loud and clear.
Okay. I've been enjoying your presentation. It's quite clear. Now, I'm happy that this issue of running clinic has come up. At the University of Rio Chichina Hospital, when I was there as a family physician, I started what we call a chronic care clinic. One of my observations was that you see all these hypertensive, diabetes, they were not properly controlled. So I raised a thing we call chronic care clinic. And that was the clinic that we were able to see both those that have hypertension and diabetes. And that was quite interesting at the general outpatient. So if other centers can follow those concepts, because when we look at it, in fact, we are going to look at those data. When we look at it, when we now brought them together and we manage them together, one, it reduces the number of visits they come. At the same time, it also reduces the cost. And that gave us an opportunity to do a strong enlightenment. The concept of chronic care clinic at the general patient is being practiced all over, even in Ghana, where these things are being done. So it's possible. It's possible for us to have a chronic care clinic. In fact, at the level of the general outpatient, so that those who have difficulty in one area where this thing is not being done can be referred to hypertensive clinic and the rest with a clear note, and that will really help us. And I also want to state clearly this collaborative approach. I'm not currently in the country. This collaborative approach where we all come together to push this concept of coexisting hypertension, hypertension with diabetes will help us a lot. But before I close, let me just ask a question. I don't know how we are battling now with the drugs, because fake drugs is becoming a big issue to us. I don't know how we are now battling with fake drugs in Nigeria. Thank you, and God bless you.
Thank you so much. Thank you.
Dr. Faso, I just want to thank the last speaker for bringing the Ghana example. So it's feasible, but let's start thinking about it.
Yes, sir.
At
Fantastic.
least the stable patient. A journey of 1,000 miles starts with a step. The fact that we are not doing it now doesn't mean that it's not feasible or it has no advantage. In some centers, it's the same senior registrar that rotates through endocrinology clinic, that rotates through cardiology, and they have the competence to take care of both. Thank you very much.
Thank you, sir. Quick one, Professor Oji. I was fascinated by the work you presented, but how were you able to define the protocol? Because if we know that yes, tax sharing, tax shifting is the way to go, but in our peculiar situation, there might be a tendency, maybe, of overstepping boundaries, not knowing who to treat and who to refer from the primary health care. How did you handle that part? Professor Oji?
Okay, before Professor Oji, Dr. Fason, can I make a comment? Because I was part of the development of that policy document.
Okay, go ahead, sir.
Yes, I was part of the development of that tax shifting and tax sharing document with the Federal Ministry of Health. And the point you have raised is very valid. At every meeting, we had raised it. For example, in the issue of management of diabetes, at primary healthcare level, we said that type 1 diabetes, they have no business with them at all. and that they can't initiate insulin therapy at that level. And so also when they are to be trained to be able to identify some complications, for example, if a patient has neuropathy, once they notice any complication, they should be referred. And then pregnancy, if anybody is pregnant with diabetes, with hypertension, for example, those patients should be referred. So there are conditions we had put in that document, but you and I know that the system we run, people love to go beyond their boundaries. That's the challenge. It's actually a challenge. How do we monitor? Of course, monitoring is very important, but do we have the capacity, the resources to do such strict monitoring as to make people remain within their jurisdiction? That's a big question that we have not been able to answer. Thank you.
Thank
So
you, Prof.
I just add that I think another reason why we just opted to train them was because, as a prof had said, whether you do it or not, they are doing it. So why don't we just train them to just know, have some basic ideas, say, okay, they too are prescribing, they too are giving drugs to this thing, instead of just leaving them blindly like that to continue to do it. Because whether we like it or not, they are doing it.
Yeah. Of course, that's what I mean. The capacity to keep training and keep monitoring, we have to take it very seriously in our setting, knowing that they will do it, because in Nigeria, the people love to go beyond their boundaries. So that's the snag about this task shifting and tax shifting in the Nigerian setting.
That's true. No, I agree. Can I just say something?
Go ahead, sir.
Can everyone hear me? Yes, thank you very much. Now, yeah, the issue of monitoring is very important. Like I said, there was a quarterly supportive supervision. You cannot take that away. And that is actually what the directors of primary health care and their team are supposed to do, because integrating NCDs into the primary health care is a national policy. In fact, there have been training, of trainers all over the states to go down and step down. I don't know how far it is now. Maybe Dr. Malawi can speak to it, but you cannot shy away from it. If we are going to tackle the burden of hypertension, diabetes, reduce the stroke, heart failure, kidney disease, and so on, we have to have a primary care approach. But then, knowing where the boundary lies is important. And that is why it's a simplified protocol. The protocol is very, very simple, easy to follow. If they can only be trained to abide by that and know when to refer, to be great. And that takes me to what Professor Marvin says. If you don't train them, they will give nifedipine sublingually. We have seen cases like that, complicated cases coming into our clinic because one committed extension worker, one nurse has done that. So we can't shy away from it. It's just like what Professor Kuti did for traditional birth attendants. And we had one of the greatest reduction, in infant child mortality, natal mortality, during that time, and even maternal mortality during the time of Kuti, because he took very pragmatic steps. I think we have to do that. Then on Professor Noma's case, yes, you can't give insulin in primary care level. It's out of it, completely out of it. The protocol is simple enough to tell you when to refer. So the issue is them being monitored. And I think that's supposed to be the duty, of people on ground, like the directors, of primary health care, the senior people there, to be able to have a team to monitor, do auditing, from time to time, and even those from the ministry. And that's why we had the primary health care board in the first place. Those are some of the things they're supposed to do, do audit. You go to a facility, you are not going to look at all 2,000 cases, but you pick like 20 of them or 30 of them. And from that, your auditing is not fault finding. Your auditing is to be able to retrain them if need be. And that was what we were doing. And you can see that in 3-year period, we succeeded in improving blood pressure control from 22% to 57%. Over that period. And now we are doing that in diabetes, but in diabetes, you have to tread more gently. That's why we're starting more with screening, but then we have done a pilot in 2 facilities about initiating treatment. And those treatments just revolved around metformin and glimepiride alone. It should not go beyond anything beyond that. They should refer, and people should know when to refer. For pregnant people, we say refer. You don't treat at that level. For blood pressure, for example, that is so or 180 millimeters of mercury and above, or 110 millimeters of mercury and above, you refer. So knowing when to refer and knowing your boundaries is very important. But it takes monitoring. But I think we have the capacity, if we are honest, to be able to monitor from the primary healthcare board. Thank you.
Thank you so much. Thank you, Professor Oji. I would love our chairman, our erudites, our teacher, Professor Baswa, to please lend his voice to this discussion. Professor Baswa, are you there? You have to unmute.
Dr. Fast, it's like sometimes they're not allowing us on mute.
Okay.
Can you unmute?
I had that problem.
Can you unmute Professor Baswa, please? The chairman. Okay. He's not a co-host. Can you unmute, sir, if you are there?
Hello. Okay. In fact, I was writing a note to say that the chairman was prevented from speaking because I could not unmute up until now. Thank you all for the discussions so far. Very interesting discussions. As regards target level treatment for hypertension in the various conditions, I think everybody is clear that yes, there will be individualized therapy, but we must limit that. The whole purpose of target is to know that many people can tolerate. If you do not have the target, there is doctor's inertia and they do not treat properly. Over the years, the target for treatment of high blood pressure has continued to come down, and it will still continue. It will still continue. If you look at the data that relate cardiovascular mortality in the general population, you will see that even within the normotensive range, the cardiovascular disease is less when the blood pressure is less, even up to 110/70. So that will continue. But the purpose of those targets for chronic kidney disease, for people with diabetes, that it should be low. Attempts should be made 120/80. Yes, it is important to stress it. However, it is always there what the patient can tolerate. So it is because of fear people were saying people cannot tolerate before, that people were allowing high blood pressure in people who can tolerate lower blood pressures. I think the point should be made that yes, we should attempt to reach target level while monitoring tolerability in the patients. I think the issue of task shifting and task sharing is extremely important, is the way to go. No matter what we say, the people will do them, and we'll continue to encourage the directorate to monitor. That is the only way we can achieve results, and I'm very happy about the results that has been achieved by the group, by Oji, that has improved control from 20-something% to 57%. I'm sure that we shouldn't ask too many questions now, because many of the presentations answer many of the questions that are already asked even before they are prepared. So that's my discussion so far. At the closing session, we'll still have one or two things to say. Thank you.
Thank you, sir. Thank you. Please permit me, because when you speak, we should be moving on to closing. But I see that Dr. Malau's hands are up. He's from the NCD desk at the Federal Ministry of Health. So I will just give him 2 minutes to make a contribution, I guess, towards the task shifting, task sharing aspect. I don't know. Go ahead, please. Dr. Malau.
Yeah, thank you so much, Dr. Fasan, and our elders in cardiovascular and diabetes health. We really appreciate this very good session. Nigerian Hypertension Society has been an ally of the Federal Ministry of Health right from inception. And we could recall the processes that we collaborated in the developing of the National Treatment Guideline for Hypertension Management in Nigeria. So we want to ask that we sustain this relationship. And for the tax shifting and tax sharing policy, the presentation made by Professor D.K. Oji is similar to what we are also implementing in Kano and Ogun State. And in fact, tax shifting and tax sharing has been an eye-opener for us now, because the management of uncomplicated hypertension and diabetes, whether we like it or not, can be taken by low-level healthcare workers at PSC facilities. They can do that, and they will decongest the secondary and tertiary healthcare facilities for us to concentrate on, high expertise level of management. And one good thing that we have also learned from the tax shifting and tax sharing is that the primary healthcare facilities are being strengthened to refer. Unlike before now, most of them tend to hold on to patients at that lower level. But with the tax shifting and tax sharing policy, they have been trained to refer cases when appropriate. And just to also announce that the Federal Ministry of Health undertook a comprehensive household survey for non-communicable disease and associated risk factors. And hopefully, the Coordinating Minister of Health is going to unveil the report very soon, and stakeholders will be invited. Of course, Nigerian Hypertension Society will be part of the launching. So this is just a statement from the leadership of the Federal Ministry of Health, and we hope that this kind of engagement continues frequently. And we thank the Nigerian Hypertension Society for participating, tremendously in the 2026 World Hypertension Day. I have seen the good work across the country. Kudos to Nigerian Hypertension Society. The president and chairman of the association, we thank you so much for your support. Let's keep it up. God bless.
Thank you so much, Dr.
Thank
Malau.
you, Malau.
Pamela, are you there?
Yes, I'm here. Thank you so much. I want to call on one of my colleagues, Dr. George or Dr. Estella. I think they had questions to ask or contribute at this point, and then we can move to wrapping it up. Thank you. Dr. George, Dr. Estella, either one of you. We can't hear you, Dr. George. Dr. George, are you speaking?
Yes, am I audible now?
Yes, we can hear you now.
Okay, thank you so much. Thank you so much to the panelists for such an insightful session. There's so much to learn, really so much to learn. I have just two questions, and it's so we have spoken a whole lot on management of hypertension, diabetes, chronic disease. So my question is, for instance, for those who are not exactly hypertensive, for those who are normotensive, for instance, and really just want to, monitor their blood sugar, their blood pressure. There's a lot of conflicting information out there as to how often they should, what measures they should take in terms of how often they should monitor the blood pressure. What are the protocols out there? How regular is it? Once a year, once in 2 years, once in 3 years? I would like if we can just just put that argument to bed, to rest, and just give more clarity as to what the frequency should be, and and if possible, why that frequency was chosen. And also, there is a lot of information out there as to how so in terms of how, so yeah, I know we also mentioned some protocols that that we could access. I want to know how we could access those protocols, and if they're available, and where we can get them. I don't know if my questions are clear.
Yes, they are. Can we have is Prosoji around?
I think any of the cardiologists can quickly answer the question. Is Professor Karai there? Hello? Hello?
We can hear you, sir.
Okay, if Professor, well, I just thought any of the cardiologists would answer the question. His question is for a normotensive person. How often should he have his blood pressure monitored? Once in, usually we would say above 40, 45, once in 6 months is good enough for blood pressure. For diabetes, for somebody with blood sugar in that range, is also asking the question, how often should such a person have the blood sugar? Maybe Professor Anuma, can you answer that?
Professor Oji is here. Professor Oji, can you go ahead, please?
I thought, okay, Professor Numa on the blood sugar.
Yes.
Or you want me to
Professor
answer?
Okay, you can answer that. Blood sugar.
Okay, yes. No, well, so we say at least once a year. That's what is taught, but it's individualized. If you have a family history, for example, of diabetes, you want it to be at least twice a year. But if you don't have a family history, why not once a year? We encourage annual checkup for those that are 30 years and above. Before this time, if you look at preventive cardiology, the guidelines will tell you that once people are 40 years and above, they should do that type of checkup. But it's come down now because of the increasing risk factors for cardiovascular disease. So from 30 years, you should have once a year checkup for your blood sugar, especially for your blood pressure, like Professor Bassan said, twice a year. But if you have a family history, it should be up to 3 to 4 times, in a year, to be able to check your blood pressure and blood sugar. You also make it more frequently, like twice a year. So it's individualized. Then, Sai, you mentioned the issue of having a protocol. Yes, so this protocol available. We can get you the link, especially for the simplified protocol for primary care, which primary care physicians can use and non-physician healthcare workers can also use.
Okay, sir. Thank you so much. I guess
Thank you.
I'll also add that if there are other comorbidities, other risk factors, obesity, sleep apnea, and other things, it will be more frequent than that. So it
More
should be
frequent, that's true, yeah.
Okay. Second, is that all you have, mDoc?
Yes, it's 5 o'clock now, so we would love to ask some more questions, but we will get in touch after the sessions and ask the questions that we want to ask after the sessions, if you don't mind, because it's 5 p.m. now and we still have to do the post quiz and the closing remarks by Professor Bassahan and Professor Mamven. So thank you very much for all the speakers for very insightful talks about hypertension and diabetes. They're not exhaustive. We can't exhaust that topic. There's a lot to do, and we're looking forward to continuing the conversations in future. Right now, we want to do a post-quiz just to understand how much knowledge we've gained. So they're the same questions that you answered before. We'll just take 5 minutes. There are 5 questions to fill those in right now. Thank you very much. So they should be up on your screen. If you can't see it, just click on the 3 dots and you will see polls and quizzes, and click on polls and quizzes, it will come up. Can I encourage everyone to participate in answering the questions? Give me a thumbs up if you finished. We have a couple more minutes. Thank you, everyone. 1 more minute. Okay, thank you very much for taking the post quiz. We're going to move on, last but not the least, to our reaction surveys. Just quick questions to see how you found the session, what we can improve on. It's really important to take time to fill it in. Again, it's very short. If you could do that, that would be really great. It helps us guide improvements in our future sessions. Thank you. Just a couple more minutes and we're done. Okay, we should be wrapping up now. Thank you so much. We're going to have our closing remarks by the chairman of the NHS, Professor Obasahen, to lead us in our closing remarks, and then we'll have a vote of thanks by Professor Mamven, and then we'll end right there. Thank you so much.
Thank you. Thank you very much. This is Chairman's closing remark. Let me say that I am sure that most participants have enjoyed this session. We thank the speakers for their very eloquent contributions. Certain things clearly stand out after this webinar. One, that the twin disease, hypertension and diabetes, are common diseases which occur commonly in our environment. Hypertension, general prevalence is around 37%, and diabetes, general prevalence in the country around 5.5%. These are common diseases. In the process, many definite remarks were made. They both occur commonly in each other, in which case hypertension occurs commonly in diabetes, and diabetes also occurs commonly. And the link, a lot of it is due to insulin resistance and hyperinsulinemia, which appears to be commoner in both conditions. Of course, there are other things like complications of disease, renal complications causing hypertension in diabetes, and sometimes treatment complications causing diabetes in people who are hypertensive. So there are many things that link these diseases together. Of course, the demography also link these diseases together because they tend to occur in people in the same age group. It's been said that both of them, their complications are not just additive, but in fact they are synergistic because they more than multiply the risk of both of them. And the point made by one of the speakers was very eloquent, that the factor that drives complications is the high blood pressure itself. Even among diabetic patients, the risk of high blood pressure is very important. That is why it is important to control the blood pressure in diabetes to very low levels. So, I mean, we have learned a lot, the necessity for task sharing and for collaboration for improved management. And there are things that we'll take away to think about, which the chairman of the Hypertension Society, Isezo, mentioned, that we should consider clinics where both diseases can be co-managed by experts. We'll think about how those things occur. So it's been a very worthwhile program for me, and I believe so for many people. I thank you all. I also thank our partners who have made this a yearly event for now, and you have facilitated it and made it very interesting. I encourage that subsequent ones will even be more interesting. Thank you very much.
Thank you, Professor Basahen. Now over to Professor Mamven for her vote of thanks.
I think she just sent a chat that she had network issues now.
Okay. All right. Well, on that note, does anyone else want to say something quickly from the NHS?
I don't know if the president is still here. I just want to say that the Nigerian Hypertension Society is an umbrella body of all doctors who are involved in the management of hypertension, from cardiologists, nephrologists, endocrinologists, neurologists, to family physicians, to, okay, Professor Mamven, you are back. I think she's in the way.
I've let her in.
Yeah, we look forward to everybody coming to join us. I've posted our website, tnhs.org.ng, and I've posted our Twitter handle at TNHS1993. Please, we look forward to having you with us. The more, the merrier. We'll be glad to have more members. Professor Mamven, can you give us the vote of thanks, please?
Sorry, my network went off. So, distinguished colleagues, ladies and gentlemen, thank God we have come to the end of this wonderful presentation. So on behalf of the Nigerian Hypertension Society, it is my honor and privilege to thank everyone as we conclude this very impactful webinar that's marking the World Hypertension Day. So we wish to thank our leadership, the President, and our indefatigable Secretary. We thank you for this vision, your leadership and commitment. To our presenters, all of you, a special thank you. We really had a wonderful time. To our phenomenal faculty of speakers, you did us very well. So we thank you for sharing your expertise, your research, and your invaluable insights. You have truly enriched our knowledge. To our host, mDoc, I'll mention some names here: Pamela, Roderick, Kehinde, Isaiah, Dr. George, anybody else that I haven't mentioned. Those are the names that I could get. We extend our sincere appreciation to you all. We thank you for the tech you provided. Thank you for your guidance, and thank you for everything you've done for us. And we pray for a continued collaboration with mDoc. So thank you very much for this. And then to our participants, all our participants, I must particularly mention Dr. Malao, coming from the Ministry of Health and joining us. As he has said, he will be continually supportive to this association. And to everyone who keyed in and joined us virtually from various parts of the country and the world, we thank you. Your active participation and engaging questions and dedication to this webinar was very profound. You made this event a resounding success. Thank you very much. So as we go about with our, sorry, please, the chairman of this occasion, I'm very sorry, the chairman, our elder, we thank you very much for finding time to chair this occasion and to support us, and for all the words of wisdom that you've given us. We thank you, sir, for honoring us our invitation. So thank you all, and have a wonderful rest of the day.
Yes, ma'am, and I observed that Professor Kadri has quietly been with us too. I just saw his name.
Wow.
And then Adjulu Chukwu has also, though he has been acknowledged, but we have not acknowledged Professor Kadri.
Thank you, sir. For
thank
that.
you.
So we thank you, Professor Kadri and Professor Adjulu Chukwu, please, and all the other profs who graciously joined us. We thank you very much for joining and for participating. Thank you.
Thank you very much, Professor Manven. On behalf of mDoc, we'd like to thank all of you, all the participants, especially the Nigerian Hypertension Society, Professor Simon Isezuo, Dr. Fasson, and all the professors who spoke today, and the chairman, Dr. and Professor Obasanjo. Thank you so much. We are so grateful for your partnership with us. We look forward to an enriching, engaging partnership as we move along for all the other things that we're going to do together, and we'll be in touch to do more things together. Thank you so much for this session, and thank you for all the participants, for those who stayed till the very end. Have a good evening, everybody. Thank you.
Thank you.
Thank you so much. Good evening.
Evening and bye-bye.